at the Office of the National Coordinator for Health Information Technology. And we are really excited to hear from the folks that we have lined up to present today. We've got folks that represent vendors, we have folks that represent healthcare organizations, we have people who represent registries, all of whom are going to talk today about new and different ways that they are approaching looking at the collection of data around quality measurement and how they're actually using that data for quality improvement. I think it is clear from the things that, that I've been hearing as we have talked to different stakeholders that we are at a little bit of a turning point or a critical point in how we think about quality measurement and how we think about quality improvement in general. This is, I think, a first step for us as ONC in listening to different perspectives that are out there and thinking about what the future of quality improvement might really look like. There have been a number of folks who have asked about the opportunity to make some public comments during this listening session. There will be an opportunity at the end to do some Q&A with our panelists. But right now for ONC, we're very much in listening mode and looking forward to hearing what people have to say. If there are specific comments that you want to send to us at the Office of the National Coordinator, you want to let ONC know about it, you want to let HHS know about it, my email is actually on the webinar, but I will give that out here in case folks want to send comments directly to me. I'm more than happy to take those. It is robert.anthony@hhs.gov. I am not going to do any kind of a long intro. I'm going to hand it over to our panelists, but I did want to let everybody know, since we have gotten just a couple of housekeeping questions, you are all on mute at the moment, so nobody will be able to make any comments to the panelists until we get to the public comment period. At least we're hoping that the phone lines are set up that way correctly and they're working. We will make this presentation available via recording via our website afterwards, and we will make a copy of the slides that are available for people to see as well after the webinar is over. So if, like many people have asked, you are unable to stay until 1 o'clock to catch all of these and you have to kind of come in and come out, you will have an opportunity to catch up on panelists later. So with that, I want to thank everyone for making the time to be a part of this. I think it's very important for us in the federal sphere to hear about the different ways that people are approaching things beyond just the way that we think about quality measurement within reporting programs. I think it's very important for us in the Office of the National Coordinator, our colleagues at the Center for Medicare and Medicaid Services, and other folks throughout HHS to really think about the new approaches that people are taking to quality improvement and what kind of impact that's really having on organizations. So although we are a small room here, there are a lot of people who are listening to this that I think are going to make a huge difference in where we take quality measurements in the future. So with that, I'm going to turn it over to our first presenter. Each of the presenters is going to introduce themselves and give a little bit of a bio where they are from in their organization and launch into their presentation. So thank you.
Thank you, Rob, and thanks to the Office of the National Coordinator for making this event possible to discuss innovations in e-measurement for quality improvement. And welcome to the several hundred folks who are joining us for the web meeting today. My name is Tom Valek. I'm a partner at Discern Health, and I will be the moderator for today's event. I have been pleased to have worked with ONC on several projects now, and most recently on this look at innovations that are happening at this point to enable quality improvement through the use of electronic health data. On the second slide here, this is not advancing the slides.
Left or right?
We'll be bringing up the agenda here momentarily. I wanted to review the objectives and agenda for the meeting. First of all, our objective is to highlight innovative approaches to managing and using electronic health data for quality improvement, as well as to engage the experts that we have on the panel today in discussion about how to achieve innovations in e-measurement for quality improvement. So after we have the introductions of the panelists, we are going to have a brief presentation from Sarah Samsel, who's a Vice President at Discern Health, on innovations that we identified through an environmental scan, both literature search and stakeholder interviews. Several of the panelists were involved in the stakeholder interview process. So we have a synthesis from that landscape analysis to provide background and get everybody thinking about innovation and e-measurement and quality improvement. And then we're going to move into the participant presentations. We have about 10 participants who are going to be joining us for either all or part of the discussion this morning. And then several of them, the majority of them, are actually going to do 5 to 10 minute presentations that the rest of the panelists are going to react to, and we'll just march through those before a break, and then we'll take a break at 11 o'clock Eastern, and then there'll be 4 after the break. As Rob mentioned, there will be a public comment starting at 12:30 Eastern, but we will be receiving input, whether it's comments or questions, via the chat function. So please feel free to use the chat function on your webinar screen and send your questions or comments to the meeting organizers, and we'll try to inject those into the discussion. And then we'll wrap up by 1 o'clock Eastern time. So with that, we will move directly into the introductions of the panelists. We'll start in the room, and then we'll go to the panelists who are on the phone. We'll just start with you, Tim, if you don't mind.
I'm Tim Pletcher. I'm the Executive Director for the Michigan Health Information Network.
Great. Thank you.
I'm Paul Tootin. I'm a Senior Vice President at Quantra, responsible for product innovation.
I'm Mickey Tripathi. I'm with the Massachusetts eHealth Collaborative.
Andy Rabin, the Vice President of Product Strategy at Premier.
Frank Opelka, the Medical Director for the American College of Surgeons for Quality and Health Policy. This is Matt Austin. I'm an Assistant Professor in the Armstrong Institute for Patient Safety and Quality at Johns Hopkins Medicine.
And if we could go to the panelists who are on the phone line, please.
Hi, this is John Kauk. I'm the Chief Medical Officer for the Louisiana State University Healthcare Services Division.
Hi, folks. This is Lloyd Myers. I'm a VP of Innovation at Premier and also co-chair of the National Quality Registry Network.
This is Stan Huff. I'm the Chief Medical Informatics Officer at Intermountain Healthcare and a clinical professor at the University of Utah in biomedical informatics.
We have one other panelist who's going to join us a little bit later. His name is David Kendrick. He's the Principal Investigator and CEO at MyHealth. Okay. So to the panelists, any questions before we get started with our presentations? Okay, well, let's dive right in then. The first panelist that we have this morning is Frank Opelka. Oh, I'm sorry. I should have paid closer attention to my agenda. As I said at the outset, we're going to have a brief introduction from Sarah Samsel at Discern of the findings from our landscape analysis. Thank you, Sarah.
Sure, and we're working on getting the slides to move forward. So let me introduce myself. As Tom indicated, my name is Sarah Samsel. I'm a Vice President at Discern Health. Over the past, I would say 15 to 20 years, I have been diving into the quality world first as a measure developer at NCQA. So a lot of the conversations we've been having as part of these projects have been really eye-opening to me and have really challenged some of the perceptions and core beliefs I had of the role of measure developers, and really challenged how we have done things historically. But I left NCQA and did a lot of measure implementation through health plans, first at WellPoint, which is now Anthem, but then in the co-op system in developing quality strategies, and again looking at how tides are turning and how we're collecting data and the type of data available in order to build new and emerging quality infrastructures. And then finally, over the past few years, I've been working with the National Quality Forum in endorsement in the measure selection process. So this project has really been an interesting almost journey on where measure development has been, but then where measure implementation is going, and then where measure implementation needs to follow in the line of the big Q, or the big quality infrastructure. So what I'm going to do over the next few minutes is introduce some of the results and the themes that we learned through some key informant interviews that were a key component of this process. Many of the folks that are here with us today, either virtually or in the room, were our key informants. So we're going to ask them to really dive into their own examples of innovation. But I'll highlight how we have developed a framework on how we're thinking about where innovation is taking place. And I'd also just like to add my welcome and thanks for those of you who have joined us and are attending, and we do hope to have the time, and certainly develop this agenda to have the time for conversation and discussion. So with that, when we started this engagement with ONC, our direction was multifold, and it was to kind of explore and understand where there are levers, if there are any models emerging on the quality infrastructure, and where there are opportunities to move toward a system that promotes better health and care, improved communication and transparency, rapid translation of knowledge for all stakeholders, and reduction in burden in data collection reporting. As with many aspects of life, as in the quality ecosystem, we really would have been nice to find an easy button. There's not an easy button. That's what we've heard over and over and over. So we quickly turned and started listening to folks on what are those key attributes of what will drive innovation, and where there are opportunities to learn, to streamline, as well as to catalyze and make something scalable for the U.S. health system. In thinking about those aspects, we came up with, and I'll attribute this to Dave Sloan over here in the corner, of coming up with a graphic or a visual on how does this all work together. And so one of our early lessons was that our evolving quality world is interdependent. It's a little bit convoluted. There are many moving pieces and parts, and while the desire for eMeasurement may be at the center of efforts, there are many components and processes that have to work together and evolve together in this electronic world. I was on all 14 of our key informant interviews, and I think every single one there were opportunities where you almost wanted to hit yourself in the head and say, well, we already heard that, but that's really a theme here. And so what this graphic is trying to do is pull together those themes and all of those interrelated pieces and parts to make sure that we at least had them documented so that we know that they're all working together. As an example, advancement in measure development can't happen in a vacuum. There are multiple aspects of health IT that will contribute to measure development and what's possible for measure development. At the same time, we're hearing more and more about the need for advanced data analytics and feedback loops. How do we get the right information to the right people at the right time to really change and advance care? But then we also heard, and I really say out of 14 interviews, we heard 12 times, how do we make clinical workflow and the understanding of what happens in the provider office kind of direct and influence measurement versus measurement influence and dictating which way clinical workflows should go? So really, one of our overall arching questions was, how do we harness this innovation in any or each of these areas to move our system forward? Or, maybe more elaborately, how do we herd cats? As we advance the slides again, we started to think about where are there themes. And I know in many of the conversations that I had with each of you, and then as the Discern team was doing their research, we were looking for themes and we were looking for parameters of innovation. And we really came through with these four top ideas. One, we heard loud and clear, and we just heard from Rob as well in his introduction and Tom in his, that quality is the objective, but also that it really needs to, and innovations need to be linked to improvement for patients. But that doesn't happen in a vacuum. There's a lot of talk about patient-centric care. There's a lot of talk about patient-reported outcomes and how we harness information from patients, but that has to happen in collaboration with the entire healthcare system. Oh, gotcha. I thought it said SAG next, sorry. And then the other thing is technology comes first. Innovations in data exchange or e-measurement cannot exceed what is technically possible. That's where we feel we have really put a group of folks together in this room who are thinking about technological advances and what we can do to harness technology and harness the power of data exchange and e-measurement. There is a continuing guide and need for alignment with clinical standards and workflows. We heard this repeatedly, and I mentioned this a little bit earlier, is that measures should not be driving the workflow, but workflow should be part of the evolution of the process to drive measurement and to capture what can really be measured. And then finally, resources and will are necessary for innovation. And I think in about all of the discussions that we talked about, where is that motivation? How do we combine resources and will to all work together to make scalable efforts and to implement some of these ideas and innovations across the nation? So with that, we took in a lot of information, both through our key informant interviews and pages of handwritten notes, as well as through a process that Discern was going through, looking at both published peer-reviewed literature and then some of the trade journals to understand what's going on there. But then we had to have a framework for what is happening and where there are steps towards either from left to right or on a paradigm or a spectrum of where innovation is happening. So we categorized innovation into a number of types or buckets. On the left, we have the incremental improvement innovators, where what folks are doing, and we think there's a lot of work in this area, and I'll talk about a few examples in a minute, but optimizing the use of existing processes and resources. And that's really kind of where we are right now, where we're kind of breaking out of perhaps the box and starting to come up with new and novel ideas. But I'd say a lot of the work that's at least published and a lot of the work that we heard about that we can, kind of name names or something along that line is really in this incremental improvement section of optimizing existing processes and resources. But then we move towards the innovative improvement spectrum, and the buckets are performance improving innovations, efficiency innovations, and novel and market creating innovations. And in, again, another area where we're seeing a lot of work, and we found a lot of examples, would be the performance improving innovations, or where we're substituting or replacing processes or products to improve the system overall. And yeah, I would liken that to where we're coming up with, as we're optimizing use of existing resources, where there might be little steps and some new parameters coming out or new ideas coming out, but perhaps they're not fully implemented, fully scalable, but we're learning from them. And then we have efficiency innovations and the novel or the market creating innovations, where we're still moving towards modifying existing, so kind of a little square within a big square. There's lots of opportunity for growth. And then on the novel side, where we're turning things on the side a little bit and where there really are some new approaches that go beyond current processes or products. And that's where we're talking about things more like natural language and areas that are emerging in our system. So just a few examples, incremental improvement. That's where I think you're seeing a lot of work, and some of that's coming out of the National Quality Forum. You're seeing it at PCPI. You're seeing it at NCQA. You're certainly seeing CMS push measure developers and measure contractors in the e-measurement space. And I think that's in the incremental improvement world where we're seeing a lot of these smaller changes, the optimization of the existing systems. There's obviously new and emerging opportunities. This is where we heard a lot about challenges and barriers. So I would say this is kind of where our current state is this incremental improvement section, where e-measure performance, the emergence of e-measures, the drive for e-measures, and all fitting those into our existing quality spectrum. But then we move into kind of the right-hand side, and really those performance and the innovation improvement spectrum. And those are kind of, when we started our research and started our key informant interviews, I would say the first few interviews, we asked the same question. Where is there a model? What is the model right now for getting us to these new innovative approaches, and what can we learn from? If we think about continuous quality improvement or the opportunity to start small and be scalable and be big, where are those ideas and opportunities? And it was really interesting because almost everybody said nobody has it quite right yet. There are a lot of steps being made, but these are, and there are a lot of smaller examples, but nobody's figured out the scalable approach. And I want to let everybody in the room share their own stories, but where we found some things in the literature would be examples in performance improving innovation, health systems that are using data warehouses with multiple data streams, and building their analytics and their function using that warehouse framework. So you're getting more to looking at a full spectrum of care within a health system, but still probably not to the full community or full interaction between different types of hospitals, clinics, and providers all the way down to the patient level. We then found examples of efficiency innovation, and specifically for an ACO that developed and is using FHIR or other data standardization opportunities. I would say that's another theme that we'll touch on in a minute or lever, is this whole concept of data standardization, and that being key and essential for getting to this big scalable model. And then finally, a novel and market creating would be a hospital that's capturing free field data notes, that's using natural language, that's getting beyond the concept that measure developers have historically worked from, that we have to be able to find standardized data. We've been finding it through claims or LOINC codes or NDC codes, but really how do we get to that point of reducing burden by being able to do free-form data capture versus any type of other data model to feed into measurement. So then leading into the presentations from each of you and continuing on the levers or the themes that we found in our research, we think back to our original graphic and thinking about the interplay between measure development, between health IT, between e-measure development or e-measurement at the center, and how to link those to quality improvement, but also tying back to data, we think about where are there levers of innovation. And so when we invited the presentations, we were really looking for opportunities to hear from all of you and have discussions from all of you, and hopefully you all pushing each other a little bit to think about where are there opportunities to move some of these levers. And so starting with electronic health records, that while they may be considered the core for data for e-measurement, it's really important, and I would even say essential, to integrate with other types of data. So I'd say, it's definitely beneficial, but I think it's beyond that in order to truly capture what's happening at the patient level and being able to capture what happens across multiple providers and provider systems for one patient to improve quality of care, not just the quality of life for that person. We have to be able to capture more than what's in an EHR. Second, validated automation is the key to burden relief. And we heard really a lot about stable and transparent automated data validation processes, and the ability to use FHIR, the ability to go beyond Category 1 implementation of some of these data standardization models, and toward the ability that all of these EHRs are able to talk to each other, or if they're not talking to each other, we're able to get the same type of information out of them. It was interesting that one of the examples here, the example that we heard most often, is the discrepancy between how the different EHR systems ask about smoking cessation or ask about smoking use. In some places you see it one time, and other times it's 5. So how do we get to a point where that isn't such a burden, and there are more opportunities to integrate what we can get out of EHRs, but also what providers are putting into them? And then a lot of innovation is happening through third-party applications that are built on the EHRs. I think the other theme that we heard is that, you know, a lot of times we heard about challenges and barriers of updating and integrating applicable data sources and the need for data out of EHRs and making it standardized. And then we heard that sometimes it's a barrier working with some of the EHR vendors, but then we also heard that there are opportunities to almost bring that in a different direction and use those vendors to be able to put a platform over the top and be able to achieve standardized data, but also those applications that can pull information together, both for access and reporting. Finally, the last two, and I've talked a little bit about standardization already, but standardization is critical for external accountability, but we also heard a lot about flexibility and the need for customization and that ability for customization. And it seems to be an area right now where the system is a little bit stymied on how do we get to an approach that's standardized, get flexible and customizable depending on who the client is. And then measurement and personalization of medicine requires granular data capture and reporting, but system or community level population management requires large-scale data roll-up. So if we're really getting to that point of what's best for the patient in a system, but also thinking broader about population health and about the tools and resources necessary for the right data at the right time, we really are looking for those opportunities for customization and personalization, and how we take this granular data and use it at the population level so that we have maybe bigger bang for the buck. So in wrap up, before we turn it over to Frank for our first presentation and also allow some opportunities for questions and answers on the research that Discern has been doing, we did identify a number of areas for further research, and that's another goal of this conversation as well. And we'll be taking notes to find out where are we continuing to have open questions and themes of open questions. And these are the ones on this slide that Discern has already identified that you know, are not the discussion questions, but more of the areas that we really feel need to continue to be pushed, where there's really not published literature, where we may have heard some themes and some snippets through our key informant interviews, but there are still opportunities for future research. So with that, for those in the room and our participants on the phone, we have a few minutes to take any questions specifically about what Discern has been doing and about how we have summarized what we've heard from each of you. But I'll turn to Tom first to see if he has any.
Thank you, Sarah. And while our panelists are thinking about what they might want to raise here in discussion, also for the members of the public who are participating via the web meeting, please send us your chat comments, questions that you might have. First of all, we are going to be writing a report from this event to ONC, and we can take your comments and questions into consideration in refining the framework here and the setup, the examples of innovation and areas for future research. But also we can monitor the chat function, and we may have some input from you all to interject into the conversation with our 10 panelists today. But to the panelists in the room and on the phone, any comments about the setup here before we launch into our first presentation?
Well, Tom, this is Frank. So I would say thank you very much for that directionally. I think it aligns with our thinking, at least, and I think it starts to lay out a roadmap that isn't so clear for everybody, but I think it opens up a lot of opportunity to ask more questions and shape it even more. So I think that's very good. The one area, as I listened to you, Sarah, that as you were talking, that is problematic for us is that we agree that there's a need for standards, for data standards in measurement. But as you get to benchmarking and you start talking about measurement benchmarking, standardization is more than just the data that's being measured. You must standardize the aggregation. You must standardize the normalization. You have to standardize the representation. If any one of those breaks down, then the comparators that you're looking for in benchmarking will fail. And we've seen this time and time again. We normalized, we standardized data with the CDC and then rigidly aggregated data in one system and not rigidly aggregated data in another system, and the benchmarks are not comparable. So standardization is not just standardizing the data elements, it's standardizing the entire process as you get to measurement and benchmarking.
Thanks, Frank. Anyone else in the room want to comment on the intro?
Yeah, the one question I had was the findings, I will say, generally resonated with me. They're sort of consistent, I think, as well with kind of my worldview. But I guess I was wondering, how applicable do you think they are sort of across care settings? I mean, in other words, from like acute care settings to sort of ambulatory care settings, long-term care facilities. It feels to me like they're probably broadly applicable, but I wasn't sure sort of what the literature base suggested surrounding that.
I don't know, Dave, do you have anything you want to offer on that?
Well, I would say I think your instinct is right that these general principles that we've outlined are certainly applicable across settings. I think we would agree that most care settings are at varying levels of technological sophistication. But the degree to which we could achieve innovation for each of those different levels may vary as well. But in terms of the need to standardize, the need to automate, the need to find creative solutions so that clinicians in any setting aren't interrupted in their workflow, I think those are broad-based and applicable.
And I hope the panelists will comment on what you're seeing and experiencing in various care settings that you work in, so that we can be specific and granular about how the innovations might be playing out differently across the care settings. Any of our panelists on the phone want to comment before we move into our first presentation from a panelist? Okay, very good. Oh, Matt, you want to?
Yeah, so I guess once again, I would sort of reiterate, I think, what others have said, which is I think this framework really does speak well to where we are at in the world of eMeasurement and quality improvement. I guess I didn't hear much in the presentation about quality improvement itself. What were sort of the reactions from your key informants or pieces of information that they shared around that, if any?
I think Dave Sloan from Discern Health, who actually led our literature search in parallel with Sarah leading the stakeholder interviews, has a comment in response, Matt.
So for the most part, the research was focused on how electronic data and eMeasurement support quality measurement, quality improvement, and then what we would find is that once groups or individuals had the quality information in their hands, they can go in any different direction. And then there were multiple variables that compounded whether or not quality improvement was actually successful. So for example, even if an organization had very good data and a very good measurement system, their success was primarily dependent on leadership, buy-in from the participants involved, training, education at the provider level, at the staff level. And so once we supply everything that an organization needs to have in terms of data and support and IT, there are other things, personal things, financial things that influence how quality improvement actually is executed. Now, the degree to which the innovations that we're discussing have a demonstrable impact on quality improvement also varies. I think many of our panelists have information and suggestions about things that they've seen that have worked and that have had a direct influence. But as I said, there's a lot of ways to approach the actual quality improvement piece once you get past just the data.
Yeah, I appreciate you raising that here at the beginning of our meeting, Matt, because it's really easy to get focused on measurement or some other tool that's an aspect of the whole quality effort and forget about making that link directly back to improvement. So as we talk about the innovations today, I'll keep in mind as the moderator to push our presenters and to push the discussion toward the connection to improvement.
If I could just add, this is Rob Lawson from ONC. I would just add, you're talking, I think, to exactly what we're looking at as a whole. There's one side of that circle, which is sort of taking the data in, but there's that other side of that circle of how that data gets proliferated and how it is used throughout the organization. I would say qualitatively, I've heard across the spectrum a number of different approaches to that, but we are absolutely interested, I think, in the same thing that you're talking about, and I would love to hear from folks, is how does that data flow back to people in ways that after it is taken in and processed, and how is that used to create that sort of feedback loop that really does improve patient care?
Thank you, Patrick. The only other thing that I would add to everything that was said here and what you've done here is just for us to all recognize, sort of the general ecosystem issues that that all of us face, right? And so we can have we can try as much innovation as we want, but there are some foundational ecosystem issues that make any sort of complete paradigm shift very difficult. So in particular, we've just got the fragmentation of of healthcare. Something like, and I was looking at this data just last week, if you look at the distribution of patient visits across the country, something like over 2/3, 68% of patient visits happen in small physician practices of 1 to 10 physicians or fewer, right? And we tend to, when we think about quality measurement, we focus on Mayo and Intermountain, where Stan is from, and these other places. When we think about those systems, and you realize that if you're looking at where most of the action happens and where, therefore, is most of the data, it's really in very dispersed cottage industry kind of settings. Now, granted, more of the costs are in the big systems and in the hospital, so maybe it's appropriate for us to focus there, but there's an inherent limitation to what you can figure out by just looking at that data, as we know. Right? So that's one huge challenge. The other is that a lot of the gaps that at least that we're seeing, and I'll talk about this more in my comments later, are related to the variation of what people do on the ground. So it's about documentation gaps. It's about the variation in local implementation of vocabulary standards, things like that, that again are not about sort of having a fancy tool. It's about people's motivations, and again, it's very much related to fragmentation of care. And whether you do it by extracting a flat file or a CCDA, or you start to think about FHIR APIs, they're still tapping into that same SQL database at the end of the day that either does or doesn't have the data, or does or doesn't have the codes mapped appropriately. And there's no fancy code map you can do outside of that if you don't understand what was in that clinician's head when they actually documented in that particular way. So those are challenges that we all have to face.
Hi guys, this is David Kendrick. I was actually listening the whole time, and I'm glad to be a part of this conversation. I wanted to agree with you, Mickey. I think that we have this this perception, I think, that as a physician, that my patients only come to see me, but there's clear literature showing that care is fragmented all over the place, which means the data is fragmented all over the place, and particularly now that we're in a world where it's not just about reporting any result, it's about reporting your optimal result, and payment is tied to it. It's much more, we're seeing the level of emotion about measurement go through the roof among providers, and that means that they're starting to really care about all those terminology issues and the issues in their EHRs, and we see just a massive, we always talk about the social determinants of health being a big contributor to health issues, maybe even more than the healthcare system itself. I think you'd say a similar thing about quality measurement, in that the process, the links in the evidence chain, and all the terminology issues and the frame of reference you use for the measurement are almost as big or bigger than whether the blood pressure is in control or not in reality as a part of the measure spectrum. So I'm very concerned that we have built in enough time to the whole measurement milieu to get through making sure the links in the evidence chain are correct and the frame of evidence is correct and so on. And I'll talk more about that in a minute.
This is John, if I could chime in. So my mantra here at LSU is that report doesn't equal improvement. So we need to provide this information that's aggregated from all the disparate sources back at the point of care for the right person, the right provider, the right patient at the right time with the right information that's actionable. Building the pipelines, our patients move through 8 or 9 different EHR systems, and building these pipelines and the cost, and what Frank was mentioning with all the things that need to happen to make this data actionable, that's what we're working on trying to solve, and that's a huge cost for every one of these systems, which explains and then shows the importance of all the things that Frank was mentioning with the standardization, normalization, and getting access to the data.
I just have one. Characterized as a big problem, or just something that was plodding along doing fine, or would you say this is a kind of more on the crisis type scale? Where is it on the overall scheme of pain points for our HIT space and industry?
Oh, I wanted you to answer. I think it's a big problem.
North Korea's here. And this is where.
Yeah, I think it's in the testing phase. But no, I do think it's a big problem.
When you say it, what are we talking about? Are we talking about measurement or performance improvement, or
the whole space of, let's just do quality measurement and quality improvement.
Yeah.
As it's currently done today.
I think
it's a burning platform, or is this something that it's plodding along? It's the incremental progress component that you put up there is going to get us where we need to be.
I'm going to say that based on the fact that we sent out this registration link and 24 hours later had 2,000 people registered for it, that most people consider it a burning issue. So,
in my humble opinion, this is an unmitigated disaster of the space. I mean, in every direction, every rock I turn over, and I wouldn't claim to be the sort of world's expert in this space, but each new corner I look at is ugly, and I can't find any really elegant part of it where people are happy and excited and believe we're doing a good job. I think we're identifying a real critical problem.
Well, so I was just going to say, it seems like there are 2 levels of issue here. One is it a societal problem that we would say, yeah, now that's been a problem for decades, but so we can't measure anything in healthcare, right, compared to any other industry. So we got that. But what makes it a burning platform for people, I think, is if it affects the way that they're compensated at the end of the day, right? I mean, there's standards of care, and there's clinical practice, and why clinicians want to be clinicians. There's all of that, but it's very hard to find any individual clinician who thinks that they're not doing a high-quality job. So the burning platform, I think, is related intimately to where are we on things like macro, and on things like pushing forward on payments that are tied to how we measure things and people's ability to improve in ways that affect the way they're being measured and ultimately paid. And there's uncertainty in the market right now about whether we're sort of pulling back off of the accelerated the throttle on that.
I think if you measure the world as it is not as near the crisis as if you measure the world where it should be. We are way off, and we are losing lives being way off. We have not leveraged digital health information to the delivery system at the moment of care to use artificial intelligence the way we should in making decisions. And we're trying to get there incrementally, and it's a very slow, methodical march because of the complexity that we have. And yet, what's happening to patients in the meantime is unbelievable. And when you see what happens in a world where they are a step above, what's happening in care there is so special. Why aren't we working on that? And these are the lives of our fellow Americans that we're talking about, and we're missing massive opportunities.
So I guess my observation in your framing of this is the conveying of the sense of urgency here wasn't really prominent when you went through it. And at least from my constituents and my perspective, I think there is a sense of urgency, a really high sense of urgency. And it's not just the payment. It's the loss of life and the medical errors and just the human suffering to navigate the space. And I think it is a fundamental component of our system, but I think this is how we measure the performance of our system. Take it or leave it. That's what this part is.
So very important to establish the burning platform. As Rob said, I think the high numbers of participation are a sign of that, and we will emphasize that in our report. I do want to remind the panelists, though, we are here not so much to talk to the problem, define and redefine the problems that we have, but more to focus on some innovative solutions. And that's what we pushed for in discussions that we've had with you previously and in preparation for the presentations you're going to do today. So I hope that you'll be focusing on the solutions and the innovation in your presentations and in our discussion going forward. So with that, if we can turn to you, Frank, for the first of our presentations, and then we'll have the group continue its discussion before our second presentation.
It's not working again.
Thanks, Tom. So I don't have any slides to go over, so we don't have to worry about not being able to advance the deck. And I'll give you an ideological overview with some strategic direction the College of Surgeons has taken, and then maybe a little bit about where we are with our tactics. Our long view of this is that measuring individual physicians with singleton measures in a payment system does not really measure quality and does not really drive improvement, and we've not engaged the surgeons in quality improvement. So our belief is that you really have to measure within the continuum and across the continuum of care. And you have to measure at the patient level and all those providers who touch the patient. So we are looking at an episode-based measure framework. Most of surgical care comes in terms of an episode of care. In fact, much of all of care comes in episodes of care. Even pregnancy has a first trimester, a second trimester, a third trimester. You can break care up into episodes to measure. There are many contributors to the episodes. This fits within MACRA. We can begin in individual physician component measures in MIPS, but we can translate this all the way to APMs and measure at an episode level with shared accountability by all providers being accountable for all the measures for a patient going through an episode of care. So that's ultimately where we are and what we've done. We've looked at this in terms of clinical content and clinical context. And then we've looked at it technologically. What do we need to do to support this effort going forward? We don't think that the EHR life cycle can fit this. It's too slow and clunky, and it's too onesie-twosie. It's not the kind of environment that allows for efficient use of a digital health system. So we're more thinking in terms of cloud overlays that actually can communicate back and forth and provide the necessary information.
to the person who's got that need, which may be the patient, could be the payer, could be the clinician, could be all of the above. So that's our approach to this, building the content and context within an episode and looking at the technological needs of doing it. We break care down into phases of care. So with surgery, we look at surgery as 5 phases of care. There's a pre-op phase, there's a peri-op phase, which is that pre-launch phase, there's the intra-op phase, there's a post-op phase, and a post-recovery discharge, post-discharge phase. In each one of those phases, there are high-value process measures. There are events. And now there's a whole new science around this. There's probably going to be a specialty developed around this called the enhanced recovery. So enhanced recovery after surgery, or ERAS. So this is catching on like wildfire, not just in the States, it's worldwide. It's in China, it's in India, it's in the Middle East, it's in Africa, it's in Europe. Everyone is talking about what are the elements for enhanced recovery, and when do they begin? They begin pre-op. And when do they end? Sometime post-op. And what are all the things we need to do? It's not just the technical elements of surgery, it's their nutritional status, it's their overall chronic disease stabilization prior to surgery, it's their tobacco cessation, it's their intra-op fluid management, it's not pain control, it's analgesia strategies. So there's a whole culture around which you can build what are the key elements that are the high-value process measures that lead to better outcomes. I'll say something briefly about outcomes. We do a lot in measuring outcomes, surgical site infections, reoperations, readmissions, and mortality. For the purposes of payment, we are tortured by small numbers. We cannot get adequate numbers in individual episodes of care to discern one delivery system from another. There's just not enough volume there. Does it mean you don't do it? No. You still use it as informing how you actually are doing and how you may want to put in an improvement cycle. So how do we actually truly measure outcomes? We're looking at this in patient-reported events of care. Those patient-reported events have 2 subgroups to them. One is patient experience of care, the kind of CAP survey type stuff, and the other one is a true PRO, a patient-measured outcome that leads to their health. We think both are important, that you've got to have both of these. We're beginning with the patient-reported experience because we have those CAPS instruments. Let's leverage those within an episode of care, but let's hurry and develop the PRO phase. So we look at these across all surgical specialties, and we've developed a general set that any surgical specialty could use, pull down, and put into the phases of care measure set, and then allow each specialty to look at specific episodes of care and design specific elements of measurement within the episode. So the ERAS, enhanced recovery things are general. What's your analgesia strategy? What's your fluid strategy? But then your total hip quality of life question for a hip replacement is that specific episode component you'd want to know. Bringing that together and making the whole team, the primary care, the pathologist, the anesthesiologist, the surgeon, all responsible, because that's what the patient thinks they have. It's a team-based system, and it is team-based. Care is too complicated today to be parsing us out into elements of payment. Even as Mickey was saying, that the care is distributed, so we need to pull all that together in what is coming together in the life cycle of that episode of care. On the technology side of this, and I'll kind of close with just our highlights here, we have had 7 registries that are international registries collecting data around the world. They've all been in different platforms. They've all used different data elements. We're done with that. 3 years ago, we began a project to go to a single platform and start standardizing our own information and moving through that process. We began with the National Surgery Quality Improvement Program, NSQIP. We're not quite at 50% of the data in automated flows, but there's a lot of other judgment that needs to go into the manual entry of some of this data that we're going to have to still figure out how do we create the structural capture of those data elements, but we're in that process. A national cancer database, we've got, I don't know how many millions of lives that are in the National Cancer Database, but that National Cancer Database is the largest cancer database in the world. We're now at a point of how does that fit on the same data element platform that we've got NSQIP in, and how do we take what are highly structured things like staging and create interoperability in staging.
So here it is. It's got clinical context and content truly outlined in AJCC standards. Why aren't I writing that interoperability piece? So that's a set project we have as part of our national registry efforts. How do we join with NCI, NIH, HSPC? How do we join with the VA and the Commission on Cancer and pulling together that interoperability piece that just as staging alone would be a huge lift in moving us forward in cancer. All of our activities on the platform are mobile device enabled. So, and it all links into the billing system that we currently have within CPT. So we want that ability to have the mobile point of data entry, even to the point where our patient-reported experience and patient-reported outcome efforts that we're building today are being built on the same platform. So we want all of this connectivity to flow together and to all be digitally enabled. There's still a lot of work to do moving forward where we've got structured clinical data. How can we get that moving forward in an interoperability project? Talking with folks like Stan Huff and Chuck Jaffe and folks like Mickey, how do we move this forward? So we take what we have in scope of work and clinical content and begin that mapping process and the binding process that we need to create this for interoperability. All of this fits back as infrastructure components, foundational components that move us back up to how do we actually measure an episode of care in a meaningful way that gets closer and closer to real time and delivers back, if ultimately our goal, so let's take that cancer patient. Right now, they don't have at the point of care the NCC guidelines delivered to every clinician who's taking care of that patient. We need to build that in. Those are national standards. We need to build that into the flow. But that's only to get the care standardized. We then need to track those outcomes by patient, by genomic profile, and understand if the treatment plans we design for everyone truly fit everyone, or if we don't need to take machine learning and rework our clinical decision algorithms based on more information. And that's the point where, to our point, that we're missing a huge opportunity because we're not aggregating all this data and all the energy it has to reteach ourselves about our clinical decision support that we currently have. We're living on the current science, but we could push the science to a whole new level. So that's our short view and our long view and a little bit of our strategy and a little bit of our tactics.
So thank you very much, Frank. That's a great opening presentation for us. To the rest of the panelists, Frank has described an episode-based framework that works off of a single platform, uses mobile devices, and also has a cloud overlay. If you would just like to react to Frank's presentation, maybe pose a question to him or to the other panelists, it'd be a great way to get the discussion started.
So Frank, this is Andy Raven. So the goal is to move NISQUIP to more of an electronic data capture system, which historically has been more of a manual system, but you're saying about half the data right now is flowing electronically. What are the challenges that you see with kind of that long tail of data elements, to actually capture? Do you think that that's an achievable goal?
I don't know that we'll ever get to 100%, but part of the challenge is you need inputs from various aspects of the surgeon's experience of surgery that are clinical inputs that are not yet in structured fields that we'd have to capture. It's interesting, we don't know how many of those actually influence the measurement side. So we may actually already have what we need in terms of measuring outcomes, but there may be other elements of this that are unique to aspects of care that surgeons want to know, but we don't know how meaningful they are toward the outcome. Right. So that, right now, we haven't explored that. We're just identifying what we've got and what we don't have.
And that's an active area to identify how that data influences the outcome, whether or not that's relevant or not.
Right. Right, is an artery hard and calcified and you can't put a needle through it, or is an artery soft and buttery and you worry about whether you can cinch a suture down? It's those things that are within the context of what the surgeon felt in the course of an operation that, when you're sewing arteries together, that we may capture that in some form, but was that meaningful and actionable toward the ultimate outcome?
Hey, Frank, following up on
We've got one more comment here in the room, and then we'll go to the panelists on the phone.
Yeah, I just wanted to follow up on that. Is there an opportunity, or I don't know if you all have explored this yet, to use like natural language processing around kind of post-operative notes to see if some of those sort of insights can be found in that way, because that gives you a little bit more context, I would imagine, that wouldn't necessarily exist in structured data elements?
Great question. So part of the team is exploring with Google Verily some of the various aspects or approaches of what could we gain from natural language processing. That's in its not even infancy yet. It's barely a born child, so it's got a long way to go.
And it's been that way for about 10 years.
Yeah,
20 years.
But to the point of synoptic reporting, we do have a couple surgical disciplines who actually take specific episodes that lend themselves to synoptic reports and are creating great arrays of structured data. How that will flow and move forward and interface with all this, still, we haven't drawn those connections. We're just in the early phases of, particularly in the area of the American Society of Breast Surgeons, they've done a lot in creating synoptic reporting for breast care.
So someone on the phone wanted to chime in?
Oh, yeah. Hey, this is David Kendrick. Frank, thanks for that presentation. And enjoyed it. I was going to ask something a little bit similar to what's been asked, but maybe more detail about how you, like, what is the provenance of the data you have access to? Because I think some of the important variables you're going to need, you're walking into my primary care clinic or my emergency room has post-op issues. And do you have access to that kind of data? And if not, where do you get it?
Yeah, there are, in the continuum of care across an episode, most of the triggers that we have are based on claims that tell us an event has happened. So there are interfaces between what we can clinically currently aggregate and what we know from a claims interface as well. So the two are important, and the closer we can get to that patient cloud that has the longitudinal mapping, then we would have an opportunity. So we're strong advocates for these efforts to create the consumer-directed exchange of information that allows us to get more at those other clinical parameters. Short of having those, we actually are now in another project that parallels this, that deals with identifying events related to the episode based on cost information.
And how you're getting claims feeds out?
So we have, through a program and an introductory effort that were just made with CMS, and we're working with one of the Blues plans, and there's two more Blues plans that are also entering into the mix. We have used the CMS software system, the episode grouper system, and we've created 54 episodes that are completed. There's 200 episodes in the pipeline that allow us to take an episode of care and completely define it based on its expenditures across the episode window. And in there, you can also see sequela. You can see events that are clearly occurring. But that's pretty well flushed out. So it allows us to, let's say, go inside an ACO. We can completely pull together episodes of care, those 54 episodes of care in an ACO, and note variation.
For when the ACO has gotten access to the claims data for the risk patients.
Which they all did.
For the risk patients,
yeah.
So David Kendrick, we're coming to you for the next presentation, but before we do that, I just wanted to ask Frank, you mentioned cloud overlays for the provision of information where it's needed, when it's needed. Could you say a little bit more about how you're connecting the single platform of data to the access to that data through the cloud overlays?
So this is a connection to our platform. Take the cancer example. If a patient is entered in the surgeon's office. Anyone in the surgeon's office who signs in can enter in that data and exchange that data and pull in the data, let's say, for a given cancer. There are a series of clinical decision support activities that will relate to the stage of that cancer and subsequent treatment plan. That cloud environment then alerts the physician, and if their EHR will allow the alert, can actually send the alert into the EHR to be distributed throughout the EHR about the timing of events. You're 2 weeks away from beginning chemotherapy. You're 1 week away from projected start date of your radiation therapy. Are you on track? Are you not on track? What is the reason for delay, and so forth? So there's a directional exchange that's gone through the algorithms of care and alerted the provider about upcoming events related to that episode of care.
Right. So, David, I believe we have your slides up for those who are participating in the web meeting. You'll have to let us know when to advance unless we were able to. Okay, so you should have control. If you don't, we'll work with you on that. So go ahead.
Great. Yeah, I think I do have control. I'm presenting from my own desktop. So just kind of an outline of what I was going to go through here first. I mean, simple is always better. And if you can't clearly just show it in a picture, then it may not be working. Frame of reference, I think, is something I'll dive into more detail on in the measurement here. Assigning accountability, which I think view as a separate element from measurement, but that's been rolled together for some reason at this point. Having actionable results, the scope of the data needed to get them, and then getting there from here. So just something I think we can all agree on is measures should be standardized. They should be replicable, just like other science. They should be validated. They should be timely and actionable, and this is where a lot of us have struggled with claims data for measurement, because by the time I get a claims measure sent to me, it's too late to do much about it. And it should be appropriate to the use applied, whether it's for payment or gap closure or policy setting or any other element. So this is the world that providers are facing these days in the delivery system, and it's probably similar to lots of other areas of health delivery. And you know what you see is that there are all these different programs, and we've got measurement required in all of those programs. And in fact, Medicare and most payers are betting the farm on measurement right now. And I'm very worried about our infrastructure to support that. So, and then of course MIPS, just to bring it right down to something concrete, that percentage that was in utilization for this year became part of quality reporting. And as I mentioned earlier, now that we have to actually hit a target and that adjusts your payment, it's become a very emotional thing for systems and practices to work on their measurements and to have accurate data. So the world, as I see it, looks like this. Claims data is a mile wide but only an inch deep, so it has the unique benefit of most data sets in that it encompasses most of what's happened with the patient, but it doesn't have the deep clinical variables in it we would like to have, and it's certainly not timely enough for most measurement that we would want to do for actual quality improvement and changing practice. On the other hand, the EHRs, my practice is EHR is a mile deep because it's got all that clinical information in it, but it's only an inch wide. Because real patients' care looks like this, right? I mean, it's scattered across a number of locations, so that to do measurement appropriately, we really need to have all of this so that we have the most complete picture on each patient that we're measuring. And so then in addition to that, patients, say 20% churn from payer to payer, patients change payers over time, so even the claims data itself is quite suspect in being a universal source of complete data on any given human being. So this is actual fragmentation quantified in our health information exchange. I should have mentioned that. I run an HIE here in Oklahoma. We've got about 3.5 million patients in it. And this is taking all comers, and this shows how many different EHR systems, even counting the massive big health systems, how many different EHR systems patients have their records in. And fully 42% of patients have records in 2 or more systems. And if you look only at those with chronic disease or specific procedures, the number goes through the roof to like 70 or 80% of them. And so what that means is that if I'm measuring only in one EHR, one data source, then I've probably, at least as much as a coin toss, not got the right answer. And then, of course, my fam published a study a few years ago that showed that the average primary care provider has to coordinate care with 225 other providers and 117 other organizations, which I read as 117 other EHRs. So that tells me that we've got a really frame of reference problem when we've got to decide how we want to handle it. So first, let's talk about who needs performance results. Obviously, the provider needs the performance results to be able to do something with it. They need it at the practice level, and they need it at their system level. And then payers need it because they're writing checks based on the performance that's being assessed. And so the payer needs a number that relates to their own population and not just to who the practice happens to take care of. And then public health, of course, the employer, and society. And for the good of research and the generation of new knowledge, we need to make sure that these performance results are relevant. And so if we go back to this picture, this is a scenario that I find ourselves in repeatedly when we are doing measurement. Let's take hemoglobin A1C control. It's a golf measure, lower is better. But there are actually three. So if you take these hemoglobin A1Cs, and as you know, with bedside testing, patients get them all over town. On these 4 diabetes patients, they're going to get one in every door they walk through over the course of a year. And if we do the 3 quality measures, that is appropriate testing every 3 months, control less than 8, and out of control greater than 9, what we see here is that each practice has a very different score. It's just 4 patients, and look how many different scores we've got on those 3 measures there at the bottom of the screen. Now, if I'm the person writing checks for this quality performance, and essentially the practice that has, I don't know, EHR number, or the federal source looks to perform the best of anybody, but another one that took care of exactly the same patients performs at 0, is our investment in a value-based payment model going to work at all if it's essentially a random event, what goes on with these results? And then I would add to that that when we measure, and the reason for this is, of course, because our frame of reference for measurement currently is that we hit a button in the EHR, certified EHR, and generate a measure based on the data in that EHR. And so what's happening is that each doctor in the clinic or in the system has a score based on all the patients they saw in a given year, instead of having a patient-centric measure, which would just give us 1 score for each of those 4 people. And so when I think about it, if I take the table I just showed you and turn it on its side, it's already been mentioned that we need to know from a societal perspective how we're doing. We need to be able to look at these measures from different perspectives, but you can't combine the results from these different practices. It's just 4 people, and we've got 10, 11 different scores. They can't be rolled up to a population number. So what we have to achieve is we have to figure out, this is my own perspective, but we have to start doing patient-centric measurement, because the patient is the atom, so to speak, that we can group into practices, we can group them into payer populations, we can group them into employers, we can group them into geographies, but we have to measure around a belly button in order to have the right answer and make it able to be combined. So what you see here is this population, obviously, I mean, the scores for these 4 people are much better when you aggregate the community. And the challenge with measuring in each practice the way we do now or at each doctor level is I think we create an unfortunate pressure to not take sick patients, because my score for the commercial payers will be based on all of my patients, even though I'm in a university setting with a big chunk of dual eligible patients in my clinic and only a small slice of commercial patients in my clinic. And yet the commercial payer is going to see my score as much worse than anyone else's. And I think that's part of the emotion we're starting to hear from practices about the approach in the upper left corner of the screen. So then there's a second issue, and it has to do with attribution, not just the calculation of the measure, but who's responsible for it. So this is the sort of pseudocode for this A1C control measure in diabetes. And if we look at the initial population, take a look at what I just bolded. It insists that in order to be in the initial population, the patient has to have an office visit in this clinic. But that's not who payers think I'm taking care of. They're attributing patients to me through a contract or through a bundle or through any number of other mechanisms that are not the patient showed up in my clinic. And so, and we found this to be, in our Conference of Primary Care Initiative, to be one of the most critical things for practices to understand, is that their EHR was telling them about care gaps and quality performance on patients they had seen in the last 12 months. But Blue Cross is attributing patients to them starting 6 months ago and going back 2 full years. And another commercial payer is attributing patients like this. And another payer like this and Medicare and Medicaid are doing it a whole different way. And so what you can see on this screen is that the practice was basically blind to over half the patients they were responsible for because of the fact that the quality measure baked in attribution in the definition of the measure itself rather than separating that out as a separate concept. And so what we do is we have an algorithm that runs attribution on all the data that flows into our health information exchange, and one of the first steps in it, you can see here in the upper right-hand corner, is does a payer attribute this patient to a PCP via an ACO contract or any other kind of attributed model, a bundle or an episode or something else, and if so, then we honor that. And that makes sure that when they get quality measures from us, they're always filtered by who they're attributed, what patients are attributed to them, and not just the ones that happen to walk in their clinic in the last 12 months. And so the way this presents to a practice is you can see this is a list of de-identified patients in one practice, and you see columns for each payer and whether they attribute the patient to the practice, and then you see whether in brown whether the practice claims the patient, and then you see touch counts basically, which is who are you the most frequent provider for in the last 36, 24, 18, and 12 months. And having this visibility allows the practice to find patients like this 22-year-old here that Blue Cross has attributed to this practice, but that the practice has never seen before. And if that patient happens to have high blood pressure and is not in control, the practice will unknowingly have undercut their performance. So how do we put the measure back together with attribution then? So we basically realized that all quality measures had a numerator, a denominator, and an exclude, and every human being could be in one of those states. So for all of the patients we have, we calculate the measure, and everybody's either a numerator, a denominator only, or an excluded person. And then we come back after the fact and apply attribution depending on who's asking for the performance. So if say a payer wants to know how a particular PCP is doing on all their patients, or a practice wants to know how they're doing on all their patients, then we just run their attribution and decide who's attributed to that clinic. They can see who is scored in their group, but moreover, they can see which patients are denominator only that they need to intervene on. Same is true for other providers. And then we get into the case of the specialist, which obviously is sharing care with providers usually, primary care providers usually. And this is the way we handle the specialist so that they can see if they're sharing care and they need to rely on the PCP to close the gap, or if they hold the gap all by themselves. But then we get into the model that I think is most appealing to payers and those who are paying for care, and that is the payer can just see performance on their own lives in each clinic. And this has the effect of the payer knowing not sort of the average care among all the doctors in their network, but knowing specifically for their covered lives what kind of quality product are they getting. And in the case of providers, I can know that I'm going to be judged by Blue Cross on how I manage Blue Cross patients, not on how I manage all my incredibly sick duals and others. And then, of course, public health can look at the measures just by grouping them by zip code or geography. And let's get down to who's actually paying for most of the healthcare in America, the employers, and give them a specific view of these performances. So this shift we've made to break attribution away from the calculation of the measure has been important to enable us to apply different attributions to group the results when we need to. And so instead of just having a measure, what we do is we have instead of just having a score, we actually give a practice their trending score and then a list of patients, how the patients are attributed, and whether they're in control or not over time, so they can take action on those. And these are based on real-time flow of clinical data, so measures can be a week or less old when they look at them. But now to get this accomplished, we have to fix some problems. One of them, Frank, I think it's already come up in Frank's conversation, is that the flow of information has got to be automatic and from our usual care processes. And so this is data that flows to us from EHRs. You guys are all familiar with the quality data model. What you see is a list of value sets. There are over 700 of those. And then you see across the top the EHR vendors that we've connected to our health information exchange, from which we get live flowing data. And you can see the dots there, but you can also see the places where there are not dots, indicating that for at least the time point where we pulled this report, that we were not getting those value sets from these sources, meaning the data was coded wrong, the templates were set up wrong in the EHR. But one observation I will make here is we see a lot more variability between EHRs than we do between practices who use the same EHR. So I hang relatively little of the variability on the practice themselves and more on the EHR vendors whose implementations of the standards vary more than I'm frankly comfortable with. And so what we've had to do is recognize that we need the most comprehensive data we can get. Clinical and claims data are critical for us. Everybody knows the diabetic eye exam measure is impossible to do unless you happen to be the ophthalmologist. But when we bring claims data in, we can cure a lot of the problems in that particular measure and a number of other measures. So we believe the most accurate measures are possible in that intersection, but that means that we, again, are making tweaks to the measure definitions to allow a value set from a claims measure as well in when we do that. And our payers, of course, embrace it. And we're in our second year of being the reporting agent for value-based payment models from our system. Because we have the claims, we provide practices with cost of care data as well, which is important for them and increasingly will be as MIPS migrates to that. And here's the structure we had to put together to get this data together. What we recognized was that there was a schism in the data, and the payers, the providers have always been subject to whatever the payers tell them performance is, and it's been based on claims data, but as you can see from our attribution chart I showed earlier, the provider often didn't even recognize the patients they were expected to get a mammogram on. But the opposite is also true. The payers are in a tough bind because they really can't take self-attestation of performance from a practice. They can't take me just generating a measure of my EHR and telling them, well, this is how I've done, and pay a lot of money out based on that. So we had to come up with a different model, and our model is to have a trusted third party in the middle, to which we receive all the claims data, we receive all the clinical data. Claims is monthly, clinical is real time, and we run the analytics on the combined set in the middle, and then we can report out either payer-specific, provider-specific, or what we call hybrid measures between the two, so that value can be measured and money can flow. And in this way, both the payer and the provider are sit in governance on the trusted third party and tell it how to operate. And the payer accepts whatever the trusted third party says without complaint, and the provider gets the opportunity to see their measures every day and to take action on them before their end of the year reporting because of the ability to have the real-time flow of data. So basically, it's a health information exchange combined with a voluntary all-payer claims database is what we've done. And then the last thing I'll say is I know there's some discussion about what specific information should move in order to support data, and the quality data model has really been built for a file called the QRDA1 file, which is essentially a repurposed CCDA that's structured specifically for a specific measure. And there is one measure per patient per file sent. So if I need to do 25 measures, I've got 25 measures times however many patients worth of files I've got to have to work with if I'm doing any measurement outside my EHR. And my perspective is that's kind of a high investment for a single-use file because you can't use that file to deliver care. On the other hand, we still have the CCDA, the architecture, and you could potentially put all measures in that. We get now about 20 measures fairly reliably from CCDAs, but we have to make some tweaks to the way we interpret the data. But the CCDA is extensible, so why not put in the components in the QRDA1 for each measure into the one CCDA, do a little augmentation to the spec, and then we'd have high investment in moving the file, but at least it's multi-use. It's not just, okay, now I can measure blood pressure control. It's, hey, I can actually take care of this patient because I've got their mammogram, I've got everything in one file in this setting. So I guess this is the last thing I would say is that in thinking through how to get our health system to this point, we're at a place where we've made a big investment in EHRs delivering quality measures right now, so we're there. But we really need to be thinking about having trusted third parties for measurement, I would suggest, and we've embraced the Qualified Clinical Data Registry model that was a part of the macro legislation and existed even before as our pathway forward to delivering quality measures that are patient-centric and that can be attributed to the right level, the provider, the practice, the system, the payer, the geography, et cetera. So I'll stop there.
Great. Well, thank you very much, David. David has described a patient-centric approach to measurement that separates attribution from the initial way of thinking about the measure, and then ultimately allows attribution in multiple different ways for different purposes. Any of the panelists like to respond to this approach and the value that you see in this innovation?
Hey, Tom, it's Lloyd Myers. How are you?
Okay, go ahead, Lloyd, and then Mickey's going to comment second.
Okay, David, thank you for that, and Frank, the same. I mean, I think we're starting to hear a theme here. You know, Frank brought up the layer above the HIT, which I think is going to be a common theme throughout today, I imagine. And I think that that's a, you know, a critical aspect to it. The other thing that David raises here as a theme is, do we have the right source of data for the measures that we're developing? So the idea is that, to this point, the notion by the providers have is that the data will come from the EHR, measures can be calculated in the EHR, data will be reported out, and that will kind of satisfy the need to check the box, if you will. But I think what we're seeing is, in practical terms, you know, that won't work as we move towards value, towards episodes, towards bundled payments, et cetera, where you really need to look at a aggregation of data to drive the right performance measures. And so I just posed those two questions. Number one, do we have the right approach in terms of the models that we've been thinking about and or that are in place currently? And second, do we have the right thinking going on in terms of the sources of data and how we're measuring?
David, you want to respond to that before Mickey comments? David, are you on mute?
Yeah, I was, sorry. So I was just saying, I raised the question. So clearly I think we could do a little better on the structure and approach. I feel like anytime you try to do measurement and you haven't thought carefully about your frame of reference, I mean, everybody did Physics 101, right? Your frame of reference guides how you perceive the results you calculate. So if we don't get the frame of reference right, which being, and I would propose the right frame of reference is the patient, because you can meet almost every other perspective by doing patient-centric measurement, including the patients need to know about whether their gap is open or closed. So I agree. I mean, I think we need to step back and think about what wiring and policies and processes need to be in place to get back to patient-centric measurement.
Thank you.
Yeah, so this is Mickey. So first off, David, I thought that was a fantastic presentation, and before I wouldn't have made the trip to Washington because you said everything I would have wanted to say, and you said it much better. So thank you for that. And I had a couple of things that sort of struck me. One is, which is kind of a question as well. Well, first on the payer data, just talking about that for a second. I mean, one of the things that we've, as I'll describe in my comments, and we have a data warehouse that's basically doing very similar sort of approach as you have, David, although we're not an HIE, we're a data warehouse, but we're kind of doing the same thing. And one of the things that we've seen is that the payer data that we get is often is wrong. And I'll put that in quotes. I think you did a nice job of sort of parsing out what wrong means. I mean, it's not factually wrong. They've got some reason for, creating the attributions they've created, or, the assignment of patient to a particular condition, for whatever reasons they've, it's not as if they've pulled that out of thin air. But on the other hand, what we find is that ends up becoming a manual step that we end up having to take. So for example, just this year, we're looking at this data, something like 20 to 25% of the data that we got from CMS required manual intervention for us to figure out what the heck was going on. So as we start to approach, as Frank said, 50% of what he has is electronic, something like 20 to 25% of the patient list that we got from CMS for this is the MSSP ACO contracts, we have a number of ACOs we work with, required us to go in manually and say, what the heck is going on here? Because, the data that we got from CMS says this patient's a diabetic. I have an interface to this practice. Nowhere has that clinician said that patient is diabetic, for example. Or attribution issues, right? I don't have that patient with that particular provider. Was that because my interface went live and the attribution was, the patient was there 30 months ago, my interface went live 24 months ago, so you have all of these issues. Again, it's not a right or a wrong, but it's just, it's hard to get to, sort of perfect electronic data when you have those kinds of discrepancies that require some manual intervention. The other thing that we found is partly related to that is, Frank said that he was at 50% electronic. What we found is we've broken it down by measure, and we have a range from, there are some measures that we can get like 85% electronic. None of it's 100%. But we can get some measures like 85 to even 90% electronic, and then some it's like 20% electronic. And we've sort of been forced to have to also have a manual data entry portal for either care managers or providers to supplement the electronically provided data with manual data to get all of the gaps to get their robust measure reporting. So David, back now, this is to my question now. I'm curious, have you had to do that, and how have you sort of managed that problem?
We are absolutely on the same page there. We have had to do this, encountered exactly the same things. I'll speak about your first point first. Our most time-consuming, labor-intensive effort right now is each practice has to get a handle on what they're sending into us and whether it's accurate. We've had situations where, multi-billion-dollar health systems, we're on the call with them. We say, you're really low on your A1C, your number of A1Cs being done. Is it possible maybe your bedside A1Cs didn't make it into the feed? And they realize, oh, we put them in the EHR, but nobody signed off on them. And Epic won't push those out if they're not signed off on. So they cut the call short and went and retrained everybody to get those signed off on. So it's that kind of stuff that has to happen in multiple iterations to get there. And hopefully the payers who have written these contracts have the intestinal fortitude, let's say, to have the long view in mind. And we were fortunate here in Oklahoma that our commercial payers who were insistent on these measures coming from us understood that the first few years were going to be about getting the data quality where it needed to go, and that no HEDIS benchmark or QPP benchmark was the right one. The only right benchmark was what was going on here in Oklahoma because of the data quality and its flow. And so we've had to sort of retrench and go from 12 measures to 2, and now to 3, and then to 4. And I think, one major message I would give is we have too many measures. Let's get 2 or 3 right. Get them absolutely right, and then add another one based on those lessons. So to your second point about having to correct the data and put all that effort in. I mean, that is far and away our biggest burden, and getting the payers to be on the same page with it. And I would include Medicare in this, for example, is going to be critically important, because in almost every case, it's not a provider quality of care issue we find that tanks the numbers for these practices. It is a systematic system problem with the EHR vendor. I actually have a chain of evidence slide I show that shows all the steps, a piece of data, the life cycle of a piece of data that we get, and there are like 14 steps, and at any point in that, the chain can break down.
So thank you, David. Lots of good discussion. We are going to need to move on to Stan's presentation. For those of you who had comments that you wanted to share in reaction to David's presentation and weren't able to get them in before we needed to move on, try to think about how to integrate your thoughts as we progress through these presentations. Don't lose that good thought, but maybe think about how it also relates to what Stan's going to say, maybe what Frank said, and we'll start building on the perspectives here. So Stan, we'll go to you now.
Okay. I'll just, jump right in here. Let's see, how do I advance the slides, or should I just?
We will advance for you. Just say next,
okay.
Please.
Next, please.
All right.
So I had some ideas here, and some of these we've talked about, but I think everybody has the same idea about the importance of outcome measures, so I won't say anything there. The second item is probably the most important thing that I wanted to talk about, and that is the idea that measurement is just part of what we're doing. You know, you think about gymnastics, and you know, there's the scoring and the judges and, you know, tens and whatever. But quality improvement is really about changing what we do. You know, if in the gymnastics area, it would be, how do you train? What are the best training techniques? How do I get the best performance out of my athletes? And so one of the things that I think is a real opportunity is for sharing of the implementation of interventions. There are actually two parts to this. I mean, thinking about the things that David and Frank and others have said, if we get to truly interoperable data, and I'll talk about that as the next slide, it means that you can actually share decision logic across institutions, and it brings us down to some other things that were said earlier about how do we get this into 200-bed hospitals in the community, and not just at Intermountain and Mayo and other places. But there are two specific areas. One is, for instance, you know, that variability that's occurring in how people assign denominators, how people, you know, decide who's a diabetic. Is it because it's on the problem list? Is it because somebody's ordering hemoglobin A1Cs on them, or is it because they're on insulin, or because they're on oral hypoglycemic? I mean, you know, you can make that an executable rule so that it actually is done the same way everywhere, and that'll take tweaking because, you know, it does all. Ultimately, even if you share the algorithm, it comes down to what's the data quality and is the data available. But it really makes it possible to share the logic of how you're creating the measures. But even more importantly, you think about what we're trying to do, say, if we're trying to improve the management of people who are anticoagulated. People develop really good algorithms for that, and today we can't share them. You have to recreate it in every facility, in every institution, and every EHR system. And I think we need to focus on creating an environment where we can share that. That's where I think a lot of the standardization is going to finally show a return on investment, is because we can share interventions that improve the quality of care. And so that's the thing that I would say. Everybody's already said quality improvement data should come from documenting the actions needed to care for the patient. So I won't say much there. But the other one that I think is interesting is a thought about quality registries themselves. And if we can get, again, sort of truly interoperable data and standard data definitions, then you can think about registries not being something separate and different, and that somebody goes through a chart and abstracts information to create the information for the registry. But you can think about a registry as accessing data from truly interoperable EHR systems and aggregating, thinking of it as a cohort of patients that are abstracted from that sea or that, you know, of interoperable data, rather than thinking of it as something that's created separate as a silo, as a separate thing. Because there's so many questions that we can answer if we collect the data in a reusable and standardized way that are maybe outside of what we originally conceived of as would be the function of the registry. We can look at the whole record, and we can look at interactions and associations between all data that were used in taking care of that patient, and look at confounding variables related to that. And so looking at that as an opportunity to view in a truly interoperable way across EHRs, and thinking of registries as aggregations across interoperable data rather than something separate and different, I think might serve good purpose. Next slide. So what we're talking about, and people have mentioned already about FHIR, and this is just a schematic that shows what we're trying to get to. We're trying to get to a situation where the EHR systems are supporting a truly standardized interface to their data. We're focused on the FHIR API, and we're focused on creating truly interoperable standards on top of FHIR. The Argonauts and work that Mickey is doing to standardize that data is an example of what needs to be done. But the idea in this diagram is that you can create applications that don't know anything about the physical structure of Cerner or Allscripts or Epic or McKesson or Greenway or any of those. What they know is the standard way to access and store data through standard APIs. And I won't get into the details of that, but it's possible today in limited areas, and I think we need to focus on how we generalize that. But it creates different ways of thinking about how we use and compare data, and especially about this ability to share applications, because it's this kind of underlying technology that allows us to access and use the data in ways that we haven't conceived of before, and to share executable decision logic that detects sepsis, occult sepsis in the ER and intervenes appropriately. And the same with intervening in pulmonary embolus management, selecting the right antibiotic, managing anticoagulation, managing glucose in the ICU. And those things are things that are not going to be able to be done in a good way in 200-bed hospitals unless we have the ability to share knowledge and these kind of algorithms in a shareable, reproducible way. Next slide. So thinking of just the registry, and this can be generalized to think about caring for the patient across multiple EHRs in an ACO scenario. But what happens today, if it's automated at all, you know, you have a cancer registry and you have interfaces from each different EHR, and those are different colors for a reason, because each of those, even though they're interfaces and there's some commonality, they're actually very different. They have different data mappings, they have different structures of the data. There's a lot of normalization that has to go on, and it goes on point to point in today's world. And next slide. What we're trying to do is get to the situation where in some ways it looks the same, except those interfaces are truly standardized. And what it means to the cancer registry is that they don't have to create a different interface to EHR to get the data they want. They ask for it in exactly the same way, and it comes back in exactly the same way. And the EHRs, it has great benefit to the EHRs as well. If you just, this slide builds one, so if you just push the button once more, you know, the EHRs are being asked to send data to a cancer registry and to a quality registry, a surgery registry, and if that data is truly standardized, now they can send the data, and the cost of sending that data and the cost of maintaining the interfaces decreases exponentially because it's done in exactly the same way. Now, it takes work to get to that level, so I don't want to give anybody the impression that this is, you know, all free, and it's work, but it's absolutely work that is going to decrease the cost of accessing and using this data. And again, the biggest, I think, return on investment, the biggest value is the fact that we get to a point where we can actually share executable logic that intervenes and improves the quality of care of the patients. it actually helps us know the right thing to do, not only track, not only score the game, but actually changes the plays in the game and makes it shareable, so that if we find a good play, we can share it with everybody and they can execute it and use it in their own institution. And I'll stop there. I had another couple of slides, but I think given the time, I don't want to. I want some more time for discussion. And again, I really appreciate the thoughts that people have shared already. I've been learning a lot, so it's been well worth my time just to get educated from the smart people that are on the call. So thank you.
Thank you, Stan, and thank you for your sensitivity to the time. Appreciate that from the moderator's perspective. You've described how we can better leverage data through innovative approaches in thinking about registries, for example, differently, and in using technology like FHIR. Panelists, would you like to react to Stan's comments?
Yeah, I mean, I would say sort of from a vendor perspective, this very much sort of resonates with me, particularly because, I'm not an EHR vendor, right? But yet I have to rely on the information that flows out of those systems. So to the extent that there are interfaces that maybe were not explicitly built for my purpose utilization, but that's a sort of digital exhaust that my system can feed on, that's tremendously powerful. So I don't really have so much of a question, but I kind of very much resonate with the idea of being able to do that, because we have found, and I'll talk about in the context of my presentation, ways in which, utilizing sort of existing pipes that are in place, existing data transfer that happens, it gives unique insight into like issues of patient safety that we otherwise wouldn't have, were we not able to leverage those.
Thank you.
A couple comments. This is Mickey. Hi, Stan. As usual, there was a tremendous amount of wisdom packed into a few slides. And just two things. One was I completely agree with your comments on the registry. I came to healthcare IT a little bit late, and so when you get here, you think, well, what is a registry? Why do people think of that separately? It is just, if you have the data right, you're just extracting cohorts based on different criteria. So I think that makes a lot of sense. And getting there, there's a legacy, obviously, legacy issues, and then and getting there is the challenge. The second piece that I think that everything that HSBC is doing with respect to getting more and more detail with respect to codification, semantics, all of that is hugely important for all the issues we were just talking about. And I think the challenge is I mean, A, that's challenging enough, but then B, having sort of processes where people are willing to sort of accept that degree of standardization and then use it in day-to-day practice. I think that'll be the second challenge once you get all the work done you're talking about with respect to the very detailed work that you're doing there with the FHIR resources and profiling.
So, Stan, it's Frank, and again, hello to you. We at the College of Surgeons have continued to drink the Intermountain Kool-Aid, and we think this framework resonates with where we are ideologically, strategically trying to go, and we're tactically trying to follow. I would say that it would be, we think there's a real importance for overarching governance of this model, of this framework, that needs to reach up to the highest levels of the government, because this isn't going to happen at Intermountain or the American College of Surgeons, and it is widespread and it touches everyone. And I know there's always this sentiment of we don't want bigger government, but this is one time I want bigger government, because I think there's an important amount of framing this concept, resourcing this concept, and getting the necessary buy-ins and collaborations we need. The other thing that I would say is putting this in bite-sizable pieces, this framework,
Cancer is just one, and there are subdomains underneath that and subdomains underneath that get it down into that workable piece that we need to define and the process that goes along with it, so that we can bring in and get the collaboration between the clinical content and the technological side of this. There's a real need to understand this language that's out here in the digital health and information world and how it matches to the clinical world. People talk about things like reference models and information models, and that it needs to have mapping, and there needs to be terminology binding. Nowhere was that discussed in medical school, and it wasn't in my residency. But now I know it's really important, and somehow it touches what I do when I remove a cancer, need to get it staged, and need to put it into treatment. So we need those two, clinical dictionary and this informatics dictionary, to identify that process, make it clear to everybody, put it in that bite-sizable unit that allows us to come in and do the tactical work we need to do. There's such an appetite for this, and everyone's looking for where to go. They just can't find it.
Yeah. Amen.
Yeah, good comments from the theoretical to the very, very practical. So I'm going to take the moderator's prerogative and push our agenda by 15 minutes. I'm going to ask Andy Rabin to present next, and then we'll take our break around 11:15 Eastern Time, and then we'll figure out how that impacts our agenda for the rest of our event. So, Andy?
Well, thank you very much for the opportunity to present some innovations that are underway at Premier in the eMeasurement space. And we'll actually just quickly jump through a couple slides, if you can go to the next slide, to give some perspective on Premier. It's a very large organization. It provides services to about 3,700 different hospitals in the country. A big part of those services around group purchasing. We influence about $48 billion in supply chain spend. We also work with about 1,300 hospitals as a subset of that in various collaboratives around quality improvement, for population health in different areas. The organization is actually 2/3 owned by healthcare systems in the country, so it's a very member-driven organization, and the board is made up of about 10 CEOs of those health systems. In the measurement space, we provide services to about 5,000 different ambulatory practices encompassing about 50 million patients. So we have a very large footprint in the quality reporting space. And for PQRS in the recently finished 2016 reporting year, we reported for about 41,000 eligible professionals. So we were actually the largest reporter into PQRS, and obviously with the transformation into MIPS, the quality domain will still make up a large part of that. We also provide various consulting services, and those are rated #1 in the class ratings. We can go to the next slide. The platform itself provides products in these three primary areas around supply chain management, ERP, quality and safety, which is where the bulk of the quality reporting occurs, and then population health management. To do all this, we obviously have to take in data from multiple sources, and so in addition to clinical and claims data, we're taking in various cost data, billing data, so we have hundreds of interfaces with thousands of different systems. Some of those interfaces are actually providing services back to the EHR platforms themselves. So when we look at what was meaningful use, now advancing care information for specialized registry reporting, if we flip to the next slide, we have a network of various registries running on our platform, and we help a lot of these EHRs and other data sources meet their client requirements by providing these services. So we connect the dots in multiple ways. And so this is a network of dozens of registries running on our platform for various medical specialty societies, health systems. Many of these registries are designated as QCDRs, which obviously are playing a much greater role in the world of MIPS today. So flip to the next slide. What we're going to do is talk about 3 different use cases and ways that we feel that we've driven innovation. The first use case is around what was PQRS, now is MIPS quality reporting. And the approach that we had taken was to offer multiple solutions to our clients. And so in some cases, we would offer a fully automated back office enterprise type solution, completely hands-off, data flowing behind the scenes. In other cases, we're offering almost a TurboTax-like wizard, step by step. And so providers can almost swipe a credit. They actually do swipe a credit card. It complies with all the program requirements, takes them step by step through data submission, and so on, provides feedback along the way. And many times when we work with large health systems where they have owned physicians but then affiliated physicians that are not on their EHR, they have to offer these solutions out into the community, and so we can offer that kind of mixed approach so they can cover as many of their providers as possible. The same thing on the data entry side. So we've always tried to offer multiple approaches to getting data into the platform. It's aspirational to say that all of the data will flow electronically, and that's what we're all working towards. But as Mickey pointed out, we still offer manual data entry tools. We offer upload tools. So if the practice is able to generate a report from the system that they have installed, they can upload that into the system. You can really go after the long tail of installed on-premise EHRs, so nobody is left out. And as part of that, we have a lot of data validation, data quality checks baked into the process, and then that's been mentioned a few times. We support both ECQMs and non-ECQM measures. When we get into the QCDRs with a lot of the medical specialty societies, where they're coming up with measures that are more, they're newer measures, they're kind of more research-based measures, they're based on guidelines and so on. The EHRs have not had the opportunity to kind of bake these in and codify the underlying data elements. It's often a necessity to be able to support those non-ECQM type measures. When we actually get data in electronically, typically we're bringing it in through a secure FTP transfer or direct messaging. We've actually increased our support of that, and that seems to be picking up a lot of adoption. Direct trust, really has a lot of momentum right now, we feel, and that will continue to grow. FHIR, obviously, as that gains traction too, will be another method to transfer the data. As far as the formats that we're accepting, David mentioned CCDAs and QRDAs. We accept all of those standards. We also accept a flat file format, and it's interesting to see how many EHRs actually prefer the flat file format versus some of the XML-based standards. So we kind of try to once again meet them where they're able to meet us. The calculation engine that sits behind the scenes is all custom developed. That's intellectual property that was part of the C-City acquisition of Premier about 2 years ago. It's built to scale. That's one of the challenges when you get into the space is, how do you, process millions of patients, within a reasonable time frame and scale that infinitely, because when you start to work with these large health systems, the expectation is that you can take all of their data, not just subsets of it. And so that's a big, we feel, innovation in the platform itself. And then overlaying all of this is the program scoring and modeling. And so all of the sampling rules, whatever that particular program requires, I've mentioned PQRS and MIPS specifically, but the engine can be customized to support commercial pay-for-performance programs too, and we support a number of those. Tying that into quality improvement, we provide real-time or near real-time feedback, usually based on the cadence of the data coming into the system on performance feedback. And then that can also link to the improvement activities, as part of the QCDRs and MIPS. So flip to the next slide. So similar, but this is more of a quality improvement type of registry versus a program-based registry like what we're talking about for MIPS. And so a lot of the medical specialty societies that we work with take advantage of this approach. And this is kind of checking the box under advancing care information for specialized registry submission. But in a broader sense, it provides a platform for continuous quality improvement. Some of the same tools in place. What we do bring to the table here under the quality improvement section is linking measure performance, whether that's ECQM or non-ECQM, to improvement activities. And in some cases, those are improvement activities provided by the organization that owns that registry. We also, through indexing and various algorithms to identify what the appropriate intervention is to close a performance gap on a measure, can suggest, almost like an Amazon type suggest feature, this is a learning activity, this is a guideline, this is a toolkit, this is a change package, whatever that provider needs to change their practice behavior to get better to close that performance gap. We can flip to the next slide. So this last use case extends the underlying eMeasurement platform into alternative payment model support. And so the platform is actually sitting behind both the Million Hearts APM and also the Oncology Care Model APM. So we've taken our software and it's running within a CMS data center. It has been integrated with the EIDM, CMS's EIDM system, which is really their authentication system. So providers who are participating in these two payment models log into the CMS website, and then they're granted access into our platform. And the data is also integrated with the CMS CCW around claims data for evaluation and analysis. And so it's a fairly complex process, but from a provider's standpoint, we bring a lot of the same tools to the table around manual entry, uploading of data. We can support data integration, but that wasn't within the scope of these initial projects, but we hope that that will be added at some point. And then from a quality improvement standpoint, it's generating per patient risk scores, identifying at-risk patients, and then there is on the roadmap plans to link in improvement activities too.
Okay, thank you very much, Andy. Lots of insights into the technical aspects of how these mechanisms work that some folks might want to comment on, but also you're very clear about the ties to feedback, to improvement activities, ultimately even to identifying at-risk patients. So it was great to hear both the technical and the practical aspects of your technology. Any of the panelists want to weigh in at this point?
I have a quick question. Under the quality improvement, you often talked about feedback about payment. Do you see that as being the same as feedback about sort of patient care, or do you see those as being distinct?
So in the MIPS tool that we're launching, there is feedback on your composite performance score, so you have a sense of just where you stand relative to payment, but you can also, on the performance measures themselves, drill down to look at patient outliers, and that becomes an intervention itself. Obviously, if you identify your at-risk patients, you could have a list of outliers on one measure. You can also pivot that and say, across the 6 measures that I've chosen for MIPS, which patients are, are at risk on all 6 measures. So both ways. So I would say payment, is different than actual, the outliers on the measures.
Yeah, to follow up on this is David. I enjoyed your presentation. I was curious, how do you approach attribution?
Multiple ways, and I found your presentation very interesting. So if it's a program, such as MIPS, we'll use the program rules to define attribution. We also provide analytic views that allow you to view it using different different attribution models. And so, we do give them the opportunity to look at it similar to how you presented, all my patients that fall within this program, patients that, fall within, some region within, if it's a large, IPA or something like that. But again, we'll run it multiple ways, but usually it's, if you're looking at it from the lens of a specific program, we're following the program rules, plurality of services, things like that.
Have you found that, just to follow up, have you found that that statement I highlighted in the ECQM that on screen, do you ignore that statement as well, or do you adhere to it? Because we find when we adhere to it that we can't honor programmatic items because the patient will be excluded from that provider's list.
I mean, I don't think that we've, solved it perfectly. When we're working with larger health systems, we will also, we'll run different attributions, and clean that data up before they have a final result. And so part of the process is, giving them feedback into their performance scores continuously and ahead of time before that has to be submitted at the end of the reporting year. So, again, it's not a perfect process, and there is cleanup involved.
David, I was going to ask both of you the question. This is Tim Fletcher. The electronic clinical quality measures, the QRDAs, do you have any payers who are kind of making any funding decisions other than check the box you're sending or not sending based on those?
Oh, yeah. I mean, our payers for CPC all paid based on whether the practice hit a target or not. But as I tried to explain that, picking an external benchmark based on a different method of measurement was problematic. So we went back and recalculated baselines and benchmarks for our payers, and then they basically agreed on where the knee in the curve was and said, all right, well, that'll be our target, and everybody, that's the pay line. Above and below that performance number is who gets their shared savings payment.
That wasn't the electronic, the actual QRDA file you couldn't really use for that, right? You had a.
We've never been able to get anybody to send us a QRDA1 file. They're just not automatable out of the systems, as maybe you're finding out, or maybe you solved it. I don't know.
Yeah, we do receive some QRDA1 files. It's mixed. Most of the program reporting that we're doing is to, the government, it's CMS, not private payers.
Any other comments from panelists? Okay, well, I think we've earned a break after the excellent presentations and discussions from the morning. It's now almost 11:15 Eastern. We're going to take a 10-minute break, and we're going to reconvene at 11:25. See you back.
Yeah.
Okay, welcome back, everyone. It's now 11:25 Eastern Time, and we are going to restart on the second half of our presentations. Just to recap from this morning, we had the presentation from Discern for level setting on our environmental scan, both from the literature and from nearly 15 key informant interviews. And then we had 4 presentations on innovations from Frank Opelka, David Kendrick, Stan Huff, and Andy Rabin. We were talking as a group of panelists during the break about some of the themes from the morning, and I think Mickey Tripathi summarized it best for us. He said, we've heard 3 themes. One about patient-centered approaches to measurement, particularly in our fragmented system. We need to be able to go beyond individual provider attribution and think in a patient-centered way. Second, how measurement really translates into performance and ultimately improvement by getting the data where it's needed, when it's needed. And third, that we need to keep in mind in this environment where we really have failed to meet the promise of health information technology to date, that simplification may actually be innovation at this point in our journey. Three things to ponder as we launch into our afternoon presentations. Perhaps we'll build on those themes. Perhaps we'll add some additional ones. So our first presenter this afternoon is Mickey. Do you want to go ahead?
Okay, sure. Great. Thank you. So I don't have slides. I'll just be speaking to this. It's actually a good thing because I think that if I had done some slides, they would have been redundant with a lot of what we've already heard, and this way I can be very nimble and not slavishly follow the slides as I normally would have done. Just a little bit of background on what it is we do, and then I can offer a little bit of some specific thoughts that I think are things that I don't think have been fully covered here. So my organization, the Mass Health Collaborative, we're a nonprofit organization based in Massachusetts. And we were founded in 2004 to run some pilot projects that were funded at the time by Blue Cross Blue Shield, who invested $50 million in some statewide experiments in health IT. One of the things that we built as a part of the infrastructure for that set of pilot projects was a data warehouse that was originally designed to extract clinical data out of EHR systems for the team, the evaluation team that was from Brigham and Women's Hospital and Harvard Medical School to evaluate pilot projects. So it's very much sort of thought of originally as kind of a research platform. But then as the pilot projects wound down in 2009, we kind of flipped to what we are now, which is basically we're still a nonprofit firm, but we provide data analytics and other services to provide organizations around the country. And this data warehouse moved from being a research platform to what it is today, which is a commercial data warehouse, essentially. It's a QCDR, a CMS QCDR. It's ONC certified EHR for clinical quality measures, both for both for eligible professionals and for hospitals. And we get there's about 75 million records that we have in there now, which and about 4 million unique patients. We get about 125,000 new ones a day from provider organizations across the country. And we do it very much, very similar to what Tim has, I think, described that they're doing up at Meehan, which is a post-encounter CCDA sent to us in an automated form from each of the EHR systems that we're connected to. And we take that data, and yes, they are CCDAs for the most part, although I think it was someone else had mentioned, being surprised at how often EHR vendors want to use flat files instead of CCDAs, and they definitely don't want to use QRDAs ever. So we have to face that as well. But we take that data and do all the things that everyone has already been describing, and have all of the pain that everyone has been describing of incredible variation. Unlike David, I mean, we see a lot of. David, I think, had described that he sees more variation within an EHR system than across EHR systems. No, I think he said more across EHR systems than within. I haven't quantified it, but my sense from the team is that we see just a lot within an EHR system too. So we find that we end up having to do a lot of data validation even within an EHR system. With each new practice that comes on, there's still work there to do. We can't just sort of plug it in and then assume that, well, we validated it for 1 or 2 practices and everything's fine. There is sort of variation at that practice and documentation level. So one of the things that that I've noticed that I think speaks to the issues at large is, one, there's a big difference that we found between hospital-led ACOs or ACOs that hospitals participate in versus ACOs that hospitals don't participate in. And there's just a big difference in the kinds of data you get and the amount of data that you get. In the physician-led ACOs, there's a little bit of a gap in the need for being able to get claims or something to supplement that, so you have a better sense of what the heck is going on. Is a greater need there. Now, there may be, I'm not speaking to the business side, there may be lots of business reasons that, it makes a lot more sense to have a physician-led ACO than a hospital-led one. I'm not speaking to that at all. I'm not just speaking to the on-the-ground problem of, you're always contending with, because, we have to remember that with a hospital, it's not only the acute visits that you're getting, but you're getting the EDs, but also specialists. And that's a huge, if you have an ACO and a tightly integrated kind of model where the ACO is trying to do a lot of work to sort of keep patients within a network for the improvement of care, then you've got a whole set of specialists there who are, sort of built into that hospital who are doing a lot of that work. And if you're not getting that information, that, becomes a big gap. So it's an additional thing that you have to fill. That often, if you have a hospital in the mix, it can sort of help with that. So a lot of the issues that we've confronted, as I said, are very similar. I'll just describe another project here, and then talk a little bit about some of the lessons learned. The other one that we're launching in earnest this year is for the Boston Public Health Commission. I know there's a different angle on the quality measurement piece because it's not related to reimbursement, but it's actually building on the same infrastructure. So the Boston Public Health Commission in 2006 issued a regulation called the Boston Health Equity Measure Set. So it was to measure disparities across the city of Boston with respect to race, ethnicity, language, and now gender, or gender identification. And it was promulgated in 2006, and it basically sat there because they found that it was unimplementable, because there was no way for them to collect the data in any at-scale way across the city of Boston to be able to do that. So it literally kind of sat there until 2014 or so when they dusted it off and said, it's probably time to revisit this. Because now, especially in Boston, very, very high penetration of EHR systems. There isn't a hospital in Boston that doesn't have a robust EHR system. And they sort of revisited that. And one of the things that they did when they put out an RFP, we responded to that and we won the contract to be the data warehouse for the collection of the data. And a couple of the things that they ended up discovering along the way are things that we've talked about. For example, the need to have patient-centric measurement. So the first approach that they were thinking of was they had 32 measures that were in the original regulation, and those were custom measures. So they were very much focused on their perspective with their epidemiologists and others who are working at the Public Health Commission on here's what's needed for this. So 32 custom measures in a very thick book, book of specifications. And a couple of things that they discovered along the way was one, and the assumption was that you would have those measures calculated by each of the hospital systems, then they would send them in, and then they would do some kind of weighted average, something like that, and they quickly realized that wasn't going to work. That you have issues of patients crossing systems, all that, they weren't talking about it as attribution, but there were the attribution issues this time at the institutional level, and just the noise that you would get in the data in terms of duplication. If you have a complex patient, you're counting them 2 or 3 times in different systems, you're not aware of it. So they realized that the architecture needed to be different, that they needed to have some way of aggregating or having someone aggregate that patient level and encounter level data, match up all the patients, then run those measures at an institution level, and then provide those results at an institution level to be able to do the health equity measures. So, so that was one thing that we've already talked about here, the importance of that, and that they kind of came to that as well. The other is the simplification. So we started off with 32 custom measures, and they got together a group of providers from across the city, and quickly realized that that wasn't going to work. They were non-standardized. The word, the term HL7 wasn't anywhere in the 1,000-page regulation book. Not that HL7 is perfect, but if you're talking about health IT and you don't say that somewhere, you realize, oh, we're really off in another world here. And to their credit, they kind of revisited the whole thing and said, you know what, maybe we ought to base these measures on meaningful use measures, because we know that every system, every provider organization, certainly in the city of Boston, are going to be doing that. And let's just focus on those. Even though they're not perfect, they're not what our epidemiologists say would be perfect. But again, if we can get the basics right and get a consistent set of measures across all of these organizations, we'll be in a much better position. We're doing much better than the classic perfect being the enemy of the good. So they recalibrated everything. They looked at the meaningful use measures. They came back and they said, all right, there are 19 measures here that we think would be sensitive to healthcare disparities as we understand it. So let's focus on those 19 measures, and if we could just get that consistently across all of these provider organizations, we'll be in great shape. So did another iteration, and we came back and said, well, maybe we should narrow that down to 7 measures based on the variation that we were seeing, even from the CCDAs that we were getting. So we have a data warehouse. We have commercial customers in the city who are sending us data, so we're able to, with their permission, look a little bit at the data to say, what's the feasibility of doing what you want to do, and then have to simplify it down to 7 measures. And that's what we've settled on now. So this year we're implementing with 7 measures for every hospital in the city of Boston is going to be, by the end of the calendar year, sending us encounter level CCDAs for us to be able to calculate these health equity measures. But we still have a gap. And that gap is going to be something that we're just going to have to address incrementally over time, which is a little bit of what Tim and I were talking about before, that you can't assume that you can get this stuff right at the beginning. You just have to improve it over time. And the gap that we have is around the granularity of the REL categories. So meaningful use has, 6 categories, I think, right, for race, ethnicity, language. Now, if you think about, the history of this in Boston, it was specifically to measure health equity. So not surprisingly, they had more than 6 categories in mind. And so they were looking at it and they were saying, well, I got, like 30 categories that I want, and quickly, sort of hit the wall of, uh-oh, all of these provider organizations are, some of them may be doing a little bit more than 6, but most of them are geared toward the 6 because that's what, meaningful use told them what they're supposed to do, and that's certainly what their certified EHRs are doing. So we've got a little bit of a gap that we're, sort of working with and assuming that, all right, well, then maybe that's going to be a stretch goal then. We'll launch this year with whatever REL categories people can submit on, and then we'll, sort of improve over time with that being a stretch goal, and perhaps a recognition of, this is Mickey Tripathi speaking, not the Public Health Commission. The Public Health Commission says you got to do it at the regulation. Absolutely, I wouldn't disagree with them on that. Mickey Tripathi speaking is that maybe some organizations won't get there because they may not, but everyone is going to improve along the way, and when they know that they've got that as the end goal, at least they know where they need to head with respect to that kind of measurement. So, I think that in that is, kind of, at least to me, encapsulates a number of the things that we've been talking about, which is the need that if you can do a set of simple things consistently across a lot of providers, that's a lot better than thinking about fancy rocket science-y kind of things that you may not get done with any provider, or you could probably only get done with a couple of providers. Things like machine learning, other kinds of things, NLP, it's like, well, those would be great, but we've struggled with NLP. We did a pilot with an NLP engine to see if we could improve problemless population based on text notes. So we're getting structured data from a large provider organization and their ACO. It seemed to be underpopulated, so we worked with an NLP vendor to see if they could strip anything more out of the notes, and then we built a web service so we could call that. We found that the quality of that was just horrendous, and so we ended up stopping the pilot and just dealing with improving documentation where you can, and just going with what you can go with. One of the things that we've seen with the early experiments around machine learning are, I was in an interesting conversation the other day with a large hospital organization that we're working with in Boston. We're implementing a population health solution, and the vendor, who's a very well-known vendor, was describing to them the creation of a registry, as they described it, and that they were piloting, some of the machine learning tools that they were using to populate the registry. And of course, the clinicians on the phone were asking right away, wait a minute, why are these patients on this list? They don't correspond with the registry that our own internal data warehouse had created. So what's the algorithm? And there was just silence on the vendor side until finally, we have to sort of step in and say, no, the nature of machine learning is that the vendor can't actually answer that question, right? They can't ask, and of course you can hear the clinicians, thinking, well, wait a minute, I think about the etiology of disease all the time, but, you can't give me the etiology of this, of this registry. I'm going to go back to the old way of thinking about it. Give me 4 or 5 inclusion criteria, a couple of exclusion criteria, and I feel a lot better defining a cohort that way. So, again, sometimes the simple stuff, is a lot easier to digest and a lot easier to implement, and you're able to do it consistently. A couple of the other, points I think that we've mentioned before, but I think it's worth reiterating, is the need for claims data just to be able to capture, to be able to cast the net as widely as possible. And I think that it's, I wouldn't go so far as to say it's criminal, but I'll speak figuratively and say it's criminal that providers don't have access to all their claims data. They only get it, for the risk patients, right? If you happen to have a risk contract, you get it for your risk patients. You don't get it for everyone else. As we know, even with CMS, what percent of CMS is accountable care, right? It's 30%. I don't know. So most of it's fee for service, and if you go out into the wild, that's still true. That's true for most commercial payers too. So they feel like they're getting claims, and the reality is you're not getting claims for most of the stuff that's happening. And unless you've done, something really innovative like David has done, which is bake the all-payer claims database into your model, that's great. There aren't many places I know of that have done that. In Massachusetts, it's a silo that we don't have access to. In New Hampshire, it's a silo that we don't have access to be able to do any of this kind of stuff. So that's huge. If you don't know where the care is happening, you can't possibly, it would just be by sheer coincidence that you were able to get, a lot of that data. Unless, again, the other model is that you're working with an ACO that is very aggressive about keeping patients within network, and that's your hope of being able to get most of the patients. That's not a technology innovation. That's about the ACO doing a lot of arms and legs work to get that, that utilization, in a way that you're able to capture that data. I think the last thing that I would just mention that we've already talked about, but I'd like to just reiterate the point, is the need to separate this conversation of measurement from performance improvement, because they really are two different things. So our data warehouse, for example, is very good, I think, at extracting data out of systems, and as hard as that is, that's a lot easier than figuring out what is the actionable data that I need to push back to someone, whoever that someone is, and get it into their hands in a way that's going to allow them to take actual action, right? EHR systems, there are no standards for pushing a simple event. So we have an event notification system. There's no EHR can actually take that event as a standardized transaction. So a simple event coming out of an ADT kind of, infrastructure is hard enough, let alone a care management kind of, transaction, which would be about being able to tell someone in another entity, this patient is now enrolled in our care management program. This patient is on this registry that we have calculated that is separate from your EHR system. Your care manager is now assigned to these 10 patients, right? There are no transactions for, for that to happen across systems. And it's very, very challenging for, to figure out how you're going to do that. And that's a little bit of the organizational challenge, and that you don't get the performance improvement until you can do those kinds of things at scale. So I think it's really important to separate those out and at least figure out the measurement stuff first, and then, or in parallel at least, but to think of it as a really different problem to solve than the performance improvement problem.
So Mickey, thank you very much for adding your insights to some of the themes from this morning. One thing that I've been thinking about is what you've said, that on one hand, we really need to simplify to get it right across a broad number of providers. We haven't yet accomplished that. On the other hand, I'm reminded of what Frank said earlier, that we're missing out on huge opportunities here, probably losing patient lives based on not being able to take full advantage of what technology can offer. So I'm trying to hold both of those things in my head at the same time while we're talking here about innovation, knowing that we've got to have something to build on to innovate, and yet we're really missing out on some big opportunities. Any of the panelists want to react to Mickey's
Could I speak to that comment?
Yeah, go ahead.
Yeah, no, I think I actually think it's not inconsistent with what Frank was saying. As he was talking, one of the things that I was thinking about was the measure development process. And I thought it was fascinating what you were saying about trying to figure out what data is important to measure things that are meaningful to surgeons. And I think that there's probably more of that in terms of how we develop measures to begin with, and the role of the specialty societies, I think, probably need to play in sort of helping us get to a richer set of measures that actually reflect what what the clinicians themselves feel is going on, and that doesn't require them to record data for the sake of recording data, right? That allows them to record data, and because data is always going to be a byproduct of a process, and if you want to be able to measure that process, that's how it seems to me that's how we have to think about it. Rather than right now, I think we have a little bit of the problem of those measures. We're getting rapid measure proliferation that in many cases is imposing documentation requirements on clinicians that is separated more and more from what they feel like they're doing day to day. So I think what I heard from Frank was that there's a whole bunch of stuff that they do that they think is meaningful that isn't captured anywhere in the EHR, and therefore is not represented in measures. And it seems to me that the bridge is for the clinicians and specialty societies to get more involved in figuring out what are meaningful measures. Perhaps those can be parsimonious, but just because they're sophisticated doesn't mean that they're overly complex. If they're completely aligned with A, what clinicians think is the right thing from their perspective, and it really reflects what they're doing, and B, is therefore something that is going to be data that's generated just as a part of the processes they do day to day. I don't know, Frank, if you agree with that.
Yeah, I would say you made me think of a couple of things, and it came to defining the value proposition, and I'm not even sure the government yet understands how it wants to define the value proposition, but it's quality over cost. And to what David said earlier and what Mickey just said now, to me, don't try and measure it by the specialty. Try and measure it by the patient. And so for me to measure surgical care means I've got to take a primary care, an anesthesiologist, surgery, the post-acute care, the hospitalist, the ICU, everybody who's involved, and figure out what is in this care continuum that I need to measure to improve upon and deliver at the end on the quality side of this. And then on the cost side of it, I also have to define the cost of that entire episode. Since we've done this whole project of building this episode-based ability and all-payer database analytics, I was shocked to find out how many tax IDs touch a patient during the episode. And I'll just give you an example that when we looked at CABG, and we looked at CABG coronary artery bypass in 2 different cities. We looked at a city not to be mentioned in Minnesota, and then another city in Florida not to be mentioned. And this city had 19 tax IDs touch a CABG, and this city had 63 tax IDs touch a CABG. And until I saw that, I was like, and this is risk-adjusted comparisons. What was going on here? This is a culture of consultation. This one was not. And that alone explained the variation. So variation occurs because of cultural differences in care, because of quality of care. There's lots of different factors, but until you lay it all out and lay it all out on the patient, I don't even know where to go to react to it. But once I saw that, boy, I knew right where to go.
Right. But the improvement, just to react to that for a second, how do we address the fragmentation issue there? Because you still have, so for example, we're working with some hospitals, and I won't name them, but and maybe this is a little bit of a phenomenon of the select group of hospitals who are very well known around the world, so they get patients from all over the place, right? And maybe that's the case. But this set of hospitals, for example, they have an ACO, and once you dig into the hospital, you realize that, oh, if you look at that specialist group or you look at the hospital, maybe a third or 40% of what they do is from their ACO, and everything else are referrals from all over the place. And so you sort of flip the equation, you think about it from that surgeon sitting there. It's like, well, how do I feel like I'm a part of a care team when I'm really a part of multiple, I'm only a part of a care team because you told me that, oh, here are all the other tax IDs who covered that patient, but I don't feel like I'm part of a care team, and I'm still just going to keep doing what I'm doing to the best of my ability.
This whole concept of defining the care team in the continuum that's what needs to be built, and it's part of this ERAS effort. How do I build the entire care continuum for improving outcomes of care, and then align business models, performance measurement around that? Even the ACO doesn't do that. When we study and look at what an ACO does, its primary focus is on the quick short wins in chronic care and pharmacy. Once you get beyond that, there's very little cohesiveness that comes together. How do we identify what are the cohesive needs to build high-performance teams that deliver for an episode of care? That actually hasn't occurred. And if we created the behavioral economics, the right incentives that put the alignment together that did that, we'd also have to measure it. And then we could get to success. We don't do that today.
I guess there'd have to be more consistency across all of those ACOs, or more concentration, so that if I'm a surgeon, for example, sitting in a hospital, I have a sense that, okay, well, 2/3 of my patients are kind of under that ACO. Then it's like, all right, now I'll align my behavior to that. Or I'm getting patients from 10 different ACOs, but they're all roughly asking for the same thing. So again, I'm okay there. It's where that hard in between. I'm getting patients from all over the place. I actually have no idea what ACO they're with, and each of them has something different they want me to do, perhaps. And so I'm just, again, going to just dig down and do the best that I can according to my own sense of what's the best thing to do.
Again, I caution us. I never look at the chart and say, are they in an ACO or not? I look at the chart and say, what condition that they have and who's the team? and how do I build the team around this? And we shouldn't be thinking so much about what the payment model is. We should be thinking about what the care model is.
Okay, great discussion. Thank you, Mickey, for teeing up some additional ideas. Let's move on to our next presenter, Paul Toot. Say next slide, please.
Yeah, no, I will. Yeah, so while my slides are coming up, you can go to the next one. Yeah, so just a little background on Quantros. So, you know, we do certainly quality measurement, as has often been discussed in the room, and as Andy sort of talked about. My focus though today actually is sort of to talk about a kind of specific area of quality that we haven't touched on as much to date, which is really the focus on safety and measurement of safety, because in many ways, you know, I guess I would sort of assert, having come to Quantros outside of not having had a background in patient safety, you know, it sort of struck me that from what I've seen in interoperability and exchange and kind of quality measurement in the form of ECQMs, safety probably is even sort of less advanced on the spectrum of measurement than sort of the quality side. And what I guess I mean by that is, you know, quality in many times, at least as we sort of count it, is sort of about doing the right thing or doing the right thing in the right way. Safety, kind of gross simplification, is, you know, either doing the wrong thing or doing the right thing, but doing it in the wrong way, right? So Quantros as a vendor in this space on the safety side of our business has what's known as an event reporting system we sell. So this is basically a system where it's kind of a three-act play, you can sort of think of it as, right? Like folks come to this when some sort of misadventure happens in a given facility. We've got a few hundred hospitals on network today, probably 12,000-ish care settings of some sort or other. And, you know, literally thousands of these events are reported on a daily basis. You know, a lot of those events are sort of minor in terms of the amount of harm. Some are quite severe. Some involve death. If I just sort of assumed kind of a normal distribution, while we were sitting in this room, we probably had 3 patients that died as a result of some safety misadventure. That was just reported in our system, not, you know, looking across, right, other event reporting systems. But all of these are generally, you know, start with someone in the hospital coming to the event reporting system and manually entering this event having happened, right? You know, Paul slipped on the floor, whatever the thing was. That kicks off sort of the next phase of this, which is an investigation phase. Both of those things are very manual in most of these systems today, in sort of the sort of safety 1.0 world, and they're very time-consuming to really enact within a given hospital environment. The event entry we've sped up pretty well, but the investigation process still tends to be sort of very manually driven. And as a result of that, most of the emphasis tends to be on sort of that entry investigate portion of the system. And what you tend to get out of it are just kind of reports, more or less in the forms of counts, you know, of this number of events occurred, right? So another way of looking at this, and I borrowed this from Gartner just because I tend to like it, when you sort of think about this as kind of the analytics continuum, and you apply that to sort of safety 1.0 today, like you get sort of weak descriptive statistics out of these things in the form of this number of events happened. But to get to sort of decision and action, right, there's a lot of manual effort that's required to make that happen. Even to be able to understand sort of relative levels of performance reporting, like how am I doing here on a relative basis? Because, you know, if I'm in, say, Florida, for example, where I'm from, and I have a number of patients that, you know, fall, my count of just the end of that number of events it may be very different, say, July, when we have fewer seasonal residents, versus December, when we have more and the hospital census is greater. But if most event reporting systems, ours and others in the industry today, don't do a good job of sort of letting you see that, right? And so because you don't have great sense of really how you're performing within your own organization on a rate base, or more broadly, right, across a variety of different care settings that are like yours, you don't sort of know where the problems are, right? Some of our larger, more sophisticated clients can do that work. They can sort of work internally with their IS departments to get the necessary information. But, you know, a large number of our clients, even fairly large institutions, sort of just don't have the time to be spent on that. They're chasing other types of programs, implementing EHRs, right, worrying about meaningful use, worrying about MIPS and MACRA and PQRS and all of these other sorts of things. And so they just can't spend a whole lot of time or capital or resource to sort of build, right, a systemic approach to solving for this this type of problem. So what I would assert to you and what we've been very actively working on is really trying to take event reporting systems to the next level by not just sort of making marginal incremental improvements to things like the manual capture or sort of helping to speed up the investigation phase, but really figuring out, there's data that's flowing out of these hospital information systems in one form or another, whether it's administrative claims-based data or clinical data in EHR. What can we do with sort of that phrase of like digital exhaust that comes out of these to allow us, right, to get to a place where, we had numerators, the number of times that a fall has occurred, or the number of times that the wrong patient received anesthesia, or whatever the particular element of like our taxonomy is, but really being able to get to a place of like automatically calculating denominators, right, as part of that. Because if you can do that, if you can get to sort of the denominator, you can then get to a rate base. And if you can get to a rate base, it becomes possible to do comparatives, right? And if you can do comparatives across institutions, you can get to some sort of benchmarking and percentiles to represent that. And oh, by the way, you can do other things like actually start electronically surveilling for certain categories of safety events, which is also a tremendously helpful thing because with a world where most of the reporting for these events that shouldn't be happening, it has to be done manually, you don't have a great sense in most institutions of what my rate of reporting is. But interestingly, when you sort of look at the literature surrounding this, the places that are the safest actually have the highest rates of reporting, right? Because they have a culture of safety. So they report everything all the time, right? Even near misses, the kinds of things that they should do. Whereas other places, they may happily be going on blithely, well, I didn't have that many events today. There weren't that many that occurred in our system in the year. But that's not really a function of the fact that you are a high performer. It's a function of, well, you're just not really turning in the test, right? So, sure, you think your grades are great. So this gives us that kind of a basis. So in our systems, what we've started the process of doing is building out dashboards that look like this. So we have a taxonomy of events that exist across all of the sort of categories of safety things that can happen within the hospital. And within those, then there's sort of natures and sub-natures of those events. We sort of group them kind of logically. It's applied to every one of our clients. So if you're the largest, multiple hundred facility type client, you're utilizing the same taxonomy as what a critical access hospital uses. So that ability for us to be able to look across institutions and make sure that we're comparing, apples to apples is possible as a result of this. And it gets you to this kind of a view where you can quickly see on a percentile basis, like in this sort of fictitious hospital that we have here, overall, they're actually an excellent performer in terms of safety. And even when you look sort of in subcategories, right, tests and procedures, patients, facilities, they generally look pretty good as well. But within those, you start finding, oh, there's actually areas where there are opportunities for improvement, right, relative to others. And then you can start drilling into those areas and seeing, like in the context of anesthesia care, sort of what the nature of the problems are there. So, there's an example where they're kind of statistically an average performer, but it's actually uneven, right? Some of those are a function of like in this case, sort of wrong patient being a problem where delays not necessarily being, which kind of brings me to one sort of tangential point that I think is a theme that we sort of heard from this. When you start talking about safety, but I think this is true of kind of quality measurement in general, like EHRs and information that comes from EHRs is necessary but not sort of sufficient to rounding out the picture. And similarly, trying to bring into place, interventions. I'm an information technologist, not a clinician, but as a sort of non-clinician, my guess would be, and the doctors, medical doctors in the room can correct me if I'm wrong about this, but something like a wrong patient receiving anesthesia is probably less a function of some sort of clinical attribute of that patient, right? Like the fact that I have COPD and somebody else doesn't probably is not a contributor there, right? It's probably some more environmental variable that's actually endemic to that institution that's causing that kind of a problem, some breakdown in a more fundamental process that doesn't necessarily have to do with the particular disease state that I have or severity of it in in many of these cases. So in that context, you know, that's why I would assert that EHRs, while tremendously valuable to helping to drive systems like ours, are only ever going to be able to be sort of part of the solution because there's sort of all of these other things that exist across care settings, right, in different applications, different sort of insights, some of which for like these types of events may actually even be tied to like staffing levels, right, or the relative seniority and experience associated, you know, with that. So anyway, once you get to that basis of sort of better measurement and understanding kind of where performance is working or failing, you know, that allows you really then to drive these sort of insights into both how you're doing, then what you need to do next, which suggests the sort of interventions that are necessarily clinically right as part of that. I'm not suggesting necessarily here that for patient safety that looks like clinical decision support. I mean, in some contexts, right, there's probably information that you could cull from an EHR. You could apply to sort of a role if the appropriate sort of pushback to the EHR were available. Technically, you could sort of get back into that in the clinician's hands. But other things are probably elements that don't necessarily fit sort of neatly into that rubric. But what you could absolutely do with a true safety performance improvement system is really focusing on, you know, when did those interventions take place? Was it a situation in which the sort of intervention is failing to work, or is it a problem with sort of process fidelity of the interventions just not really being followed? You know, are you really moving the needle or not? And if you don't have sort of robust analytics undergirding all of that, it's awfully difficult to sort of measure and then ultimately manage patient safety and improvement in these systems. So that's broadly the work that you know, that we're doing. We're sort of in the safety 2.0 phase of the the world with an eye towards building it in ways that are extensible to provide this kind of support to sort of the interventions that will help to move those needles.
Thank you, Paul. Thank you for bringing that safety focus. Anyone want to react to Paul's presentation?
Good. Good. I was just going to say this: the concept of sending sort of transactions back into EHRs came up when Mickey spoke. Care events, gaps in care fall into that category when I speak, and I mean safety events. You know, that sort of external clinical decision support trigger seems to be an opportunity for translating assessment of some kind into an action. And it's really unclear from standards perspective what exactly we're supposed to use from an interoperability perspective to send those messages back. Still, yeah, at this stage.
Yeah.
So the comment I was going to make was I think you hit on an important point, which is that we need to find systematic ways of identifying patient safety events. A lot of the way it gets reported today, as you pointed out, is I choose to go over to the system and type it in. And so there can obviously be variances in who decides to do that and how often they decide to do that. Are you familiar with AHRQ's quality safety review system? AHRQ has been working on what's currently for manual abstraction of charts to identify adverse events, but as I understand it, their vision is to make that so it would apply to the electronic health record, but it feels like it might be aiming towards the same goal, which is using common definitions and searching through the electronic health record for certain elements that may identify patient safety events. So maybe if you aren't familiar with it, it might be worth something to...
Yeah, no, I do appreciate that. And yeah, I mean, I have not worked intimately with it, but I mean, I have at least sort of passing familiarity. Yeah.
What have you found is the appetite for both the providers and the vendors to have you aggregate safety information?
So
obviously people are paying you to do this.
Yeah, so I mean, so we have a large customer base already that's installed, doing the manual capture of these events.
Yeah. And they want the benchmarking across, is that?
They do, yeah. I mean, I think overall, like, the desire is to be able to gain, sort of ever more out of these systems, right? Like, we've made investments in these systems, how do we really utilize them best to sort of move the needle, particularly because, again, the way the systems are set up today, they tend to generate an awful lot of just manual effort, right, in a kind of quality risk management, safety management type of office. So even as you start getting more of these events, I mean, it's an interesting phenomenon. Like now that we can do pretty effectively safety surveillance across a good chunk of our taxonomy, you know, clients are in some ways are reticent to turn that on, or they have concerns about it, or they want to turn it on in sort of limited ways because it's that sort of spigot. Now I've got to manually investigate all of it. So it's this, you know, sort of incremental problem. But there's no question, you know, I mean, it's not like they have no instrumentation. And certainly our more sophisticated clients that are large enough to have multiple facilities have some degree of benchmarking internally. But once you start getting past that layer to sort of the next layer down, they very much feel like, other than some very specific patient safety indicators, they very much have, you know, less of a sense. The other thing that they're also very interested in is, you know, the thing I would sort of describe, especially when you start getting up sort of the nascent. So I mean, EHRs, for example, is something we track in our taxonomy, harm that's caused by electronic health records or electronic health information technology, and you see a growing pattern of those events related to that occurring, right? And actually in relatively high numbers. It's not a small number of these events. In fact, we even had, you know, some number of deaths last year attributable to some sort of a problem that occurred within the context of an EHR. So that's the other place where I think there's a lot of interest in benchmarking and comparatives, because even though I may have these sort of events over here and they don't seem to be particularly severe in my environment, you know, it's kind of like the difference between, I don't know, playing with matches and playing with a gun. You know, like both have potential bad outcomes associated with doing it. But if you didn't sort of inherently know that one, you might sort of get your fingers burnt, and the other one, you might kill somebody, like we have that kind of insight because of that sort of large repository of events that have happened, you know, across a large enough number of institutions, because safety events by their nature are just a very sort of small n, you know, on any leaf of the taxonomy in any given institution. So the fact that you've had like 5 of these things occur and none of them seems to be particularly bad for you, does that mean it's something you need to focus on? But it may really be because, you know, Tim had 2 of those things occur, right? And both of them were very serious in his kind of environment. Yeah.
So I want to pause for a moment here and address our web audience. So we are receiving your chats. Thank you very much for sending those in. We are going to first do 2 things. One, compile those for inclusion in our report to ONC. And then secondly, we're going to be collating a few where there are some repeated themes in your questions and asking them to the panel during our public comment session. So that's going to be the way that we get some of the public comments injected into this discussion. So please continue to send those chats. At the end of our day today, Rob Anthony from ONC is also going to be sharing his email address so that he can receive direct input from folks about your comments to the discussion today. So there are going to be multiple channels for you to get your voice heard. So with that, I'd like to move on to Tim Pletcher's presentation.
Thank you. I'm Tim Pletcher. I'm the Executive Director for Mayan again. And Mayan, I'm not going to talk about, so I'll just say it's the state designated entity for Michigan. I'm going to specifically focus on an innovation that we call the active care relationships. And fundamentally, for us in Michigan, we're building infrastructure. We don't even call ourselves an HIE. We're more about putting this infrastructure in to enable lots of different folks to aggregate information, but do it in a consistent way. And at the core of what we do is really starts with our health directory services. It's this thing we call the active care relationship service. And fundamentally, the infrastructure we're trying to build is dual purpose for care coordination and for quality measurement. Very often, even process-wise, people-wise, data-wise, these tend to be silos that don't work off of a common infrastructure, and I'll talk more about that. And as the world changes, moving more and more to what are the program requirements for this individual to be part of a separate kind of reimbursement or a separate kind of program, or are we patient? Is this practice unit got patient-centered medical home certification from the right entity to being reimbursed appropriately for this advanced payment model? There's lots of stuff to track. There's lots of sort of basic requirements that sort of build around not only are you eligible for a certain activity, but are you participating and do you meet all the requirements? And then there's sort of the consumer piece, which ranges all the way from consumer capture of information to consent on how does a consumer want this whole space to look. But they're all parts of really the same infrastructure. And for us, we've gotten away from the term attribution because attribution brings along a particular kind of stigma. But many people look at this and see attribution. We call it an active care relationship, and you'll see why. Fundamentally, it talks about the linkage between a patient or an individual member and a provider or a caregiver or care manager or care coordinator. And it's a formal thing. And it comes to us electronically on a regular basis, at least monthly, but it could be in real time if the entity is able to submit it in real time. We get about 12.5 million of these a month for a state with 10 million people in it. And it's got some powerful information that we get. It starts off with this patient and all the identifiers that you need to do really robust patient matching. All the information about, and I'm using the primary care provider here, but it could be any caregiver. All the endpoint information, direct secure messaging address, the HIE they're attached to, specific ESI for particular EHR. What's that electronic path? And it could be multiple here. The practice unit, which we go through an elaborate process to assign OIDs on so we can uniquely identify all the physical sites in the state. The practice, which might just be an overlay. The physician group, clinically integrated network, and there's a couple more things past this, which is which advanced payment model list are they participating in. And we chop this in half and we put a big chunk of it in the health directory. So we have this updated health directory all the time for the information that we chop off of. And we then get from the long-term care facilities in real time, their ADTs. We get this from specialists, behavioral health, all the different groups. We get the enrollment and the attributions from all the payers in Michigan. So, and then we get the populations that the different contracted groups all have. And we put this together in an active care relationship infrastructure so that we can kind of get this 360-degree view of exactly who's connected to the patient with strong identifiers. With SIM this next year, we're rolling into the community-based services, so think food banks and community-based activities. We're figuring out right now how to do care coordinators and what the right legal definition of an active care relationship with a pharmacist. But our vision is to take that list and then continue to sort of expand with these simple connectors, if you will, that link to the different entities and increasingly certain kinds of flags and risk scores. But again, it's more about context than content. We're really trying to get the context of who's connected or what are the attributes of a particular individual. And this is along the lines of, hey, instead of focusing on trying to get the content right, which we've tried for many, many years, let's go back to what Mickey said earlier, is that the problem is the system is quite messy. If you've ever looked at a person and just made eye contact and the two of you have known exactly what you were thinking or talking, you know how powerful context is. And so the idea is just by showing you the appropriate context, we can begin to do a lot of very powerful things. So the way this works is different provider type entities declare these linkages. And there's a lot of different kinds of ways. They could be reported, they could be classic, derived from an algorithm and attribution, but we collect all of them. So there isn't only one view. We get all the views of what's really going on, and we treat it like it's a dialogue, and we call that our ACRES, our Active Care Relationship Service. And then we populate that with, we send it over to an NPI, and we assign a common key service to it. And we send these common keys back to everybody so they have an additional attribute that they can use to help with their matching. We also take the provider information and we use it to populate the health directory. And then we pull out of that the endpoint information from the EHRs and we connect that. And then what happens is we go to institutions. So we have all the hospitals in the state and all the emergency departments send their ATs, obviously. We have about 85% of all of them sending their care summaries. And we take those, standardize them, clean them up, look at the active care relationships, look where to send them in the health directory, and we send them back to where everybody needs to go. And this push process, we all want to get to a query process, but what we are systematically doing is leveraging policy levers and financial incentives to clean up the data. And the basic idea is we want to really reduce the cognitive and technical burden on providers. Just send it all the time, and we're going to give you a report card. We're going to give a report card to the people who pay for care, regulate care. It says how clean or dirty your data is. And then we'll use the active care relationship service and the common key service to redistribute that. And it works. So let me flip, that was care coordination. Let me flip to quality. So we're pretty technical, and so we started off at the basics, just looking at all the different quality programs, and we went, wow, what a mess. And this was a couple of years ago. And when we show this Venn diagram to providers, they about tear their hair out and eyes bug. And it looks like there are 3 quality measures that are fairly consistent across all the different programs. Three of them. But what's disturbing is when we look at how those 3 are collected and captured, we have identified at least 23 different ways that those 3 that are in common are captured. And so that just basic blocking and tackling, we believe we need a report once infrastructure. And David referred to this as a trusted entity in the middle. But this report once, providers should be able to do things one time and get it done. And it's not that way. He mentioned the MyFan article. It is not that way today. There are literally hundreds of opportunities. The other thing is that the way people get paid is usually based off of these flat files or these proprietary formats most of the time, certainly in the commercial world, okay? And so you've got these proprietary formats that then all go in different ways to get delivered to the different health plans. So what we've begun in Michigan is this report once, where we go to the organizations and say, send us all of your supplemental clinical information. And we managed to get all the other payers to agree to the dominant payers format in our state, the dominant payer's proprietary format in our state right now, by just making it all payer. Okay, so folks can report once, all payer. We use the active care relationship service. Now we get these enrollment files from all the payers to break it apart and redistribute to all the payers that supplemental clinical information. And it helps some of the smaller plans who just aren't big enough to get the other providers to actually participate. So it helps everybody get a little bit more data. So the vision that we all want, or we believe we want, is that we'd love to have these electronic clinical quality measures, category 1s, come out and get delivered to all the health plans who would do their roll-up. But what we've had to do is take the supplemental clinical information and convert it, because we don't find a lot of health plans or groups that are reimbursing using these electronic clinical quality measures in their day-to-day. And so what we end up doing is we take that supplemental clinical information, we route it through and really deliver it to the traditional places. And this is the big concept that I want to make, is that we need a transition path to get to the new stuff for people. So they can send the supplemental proprietary pieces, but then at the same time we fork off a way to convert it so we can begin to onboard all of these different groups to electronic clinical quality measures so they can compare what they used to get in the proprietary world to what they're now getting in this electronic clinical eMeasure type world. And then as this stuff starts coming not in a proprietary format but as an actual QRDA, we can automate it. And the reason we want to automate this is because the gaps in care reports are equally bad coming back. No payer has standardized on how to send the gaps in care back. And so if we all have a vision that what we want to do is get this to be a transaction, not a once a year kind of, yeah, send me a check, check the box, we have to turn this into kind of a dialogue where quality measurement starts to feel a little bit more like closing gaps in care from a care coordination perspective. And so what we do is we get that supplemental clinical information and we go to send the gaps in care back. But I would love to know from anybody on this panel if you know of a standard for sending a gap in care, actually even representing a gap in care, because I haven't found one. And we would use it if there is one. Okay? But then once that gap in care comes back, there's still time to close the gap and to communicate back to the payer that you'd like to fix it before everybody gets penalized. But then if you're trying to do patient-centric, and I think David said that really well, you can also use that gap in care to go back to everybody else who has an active care relationship or a linkage to that patient and say, let's just close the gap in care. So we can focus not on the report and just the payment, but getting that message out to everybody. Thank you.
Thank you, Tim. You covered a lot of ground very quickly, succinct presentation that I think made a lot of sense at this point in our series of presentations. Anybody want to react to Tim's comments?
I mean, the closing the gaps in care thing, that does really resonate. I mean, that's just one of those areas that if you're interested in just measuring quality, that's sort of one thing, but if you're really interested in improving it, you've got to figure out some way to be able to close that loop and then get that information back into the system. And then, you know, I mean, it has to have that kind of feedback loop. If you don't have that, it's awfully hard to move the needle.
And I would add to that timely feedback loop.
Yes.
Right? I mean, if we get too far from the delivery of care.
The other thing that's interesting is with these active care relationships over time, you know, they expire, but you have the expired ones. You have a history of exactly how individuals have moved through the system. And by packaging up those active care relationships, I can give it to somebody with an all-payer claims database or with a clinical repository and say, here, do you want to do a couple different views of how attribution might work in a number of different settings, or your clinically integrated network? Here's what the payer community thinks the attribution was, but here's what was really going on for a treatment history or a relationship history. Is there a gap? Is that gap meaningful? If you calculate it one way, do you get different payments than if you calculate it another?
How much of the payer market is participating? I
Well,
think it's great.
well, we got them all participating. Only maybe about 5 of them are really in the first stages of really doing it. But the payers are pretty enthusiastic about this, and then we've probably got about half of the major POs, so a pretty sizable chunk of the doctors, and it will be a large portion of covered lives. SIM has also kind of lined up, said they're going to follow this exact process for everything. So the big trick in Michigan is we've got the commercials and sort of Medicaid in step with each other, which is non-trivial.
We're talking about here about innovation that could hopefully be replicable. How replicable do you think? And I know you have to do a lot of bottom-up state work, a lot of convening.
I think people have to buy, as they struggle through attribution and it being broken, that they have to buy, and as they go into the communities and try to do social determinants of health, and as they look at care coordination and go, my God, what another big mess, right? And as they move into health risk assessments for patient-reported outcomes and go, wow, what another mess, okay? It's all the same basic problem of how does everybody connect to the patient. So I think it's very repeatable, maybe not exactly the way we've done it, but conceptually, everybody seems to be arriving at you need to understand this map to the patient. When I look at Commonwealth and sort of how they're putting pieces together, there's pretty good alignment with the link level of assurance, but it doesn't sort of extend out far enough yet. So I mean, I think people will move in this direction. The 21st Century Cures said, hey, we got to have a directory that works. I think that's what one of the things it said. That stuff is all infrastructure that has to be here for us to sort this out in an intelligent way.
Okay, now we're going to move to our last presentation of the day before we go to some of the public comment questions.
Tom, how long should I take?
You can take 10 minutes.
Okay, wonderful. So, I'm going to talk a little bit about how measurement can serve as an important component of quality improvement work. I think David Sloan touched on an important point earlier today, which is that, when we think of quality improvement, we also need to think of culture, we need to think of leadership. Obviously, measurement's an important component of that, but it's just a component. What I wanted to share today is an example of how eMeasurement has supported a quality improvement project at Johns Hopkins Hospital, specifically at the point of care, and how that can align with clinical guidelines. Before I get going, I should just give you a little background on the Armstrong Institute. We are at Johns Hopkins. Our institute actually has two roles. One is to coordinate and support quality improvement efforts across Johns Hopkins Medicine, which includes 6 hospitals, 38 practice, clinician practice, some ambulatory surgical centers, etc. The other role we have is to do research around quality and safety and to disseminate those results both nationally and internationally. So the example I'm going to be sharing today is more from the first role, which is coordinating and supporting the work within Johns Hopkins Health System. So back in 2012, Johns Hopkins Medicine's board decided that it no longer wanted to just be average in terms of quality and safety, but that Johns Hopkins should be national leaders in quality and safety. So then that raised the question of, well, how do we define national leadership? So we actually looked at 2 external agencies or entities that issue quality and safety awards, one being the Joint Commission, the other one being Delmarva, which was our state QIO at the time. And they both gave out annual awards based on hospitals' performance on the core measures. So when we looked at the criteria for both of those awards, we identified that if we achieved 96% performance on each of the measures every month, that we would qualify for both of those awards. And so that became the goal across the health system in terms of where we wanted performance to be on the core measures. In terms of a conceptual model, in addition to sort of stating that goal, we were very clear in how we were communicating that goal across the health system to all staff and physicians, how we could build capacity for quality improvement with Lean Sigma, transparently reporting performance, and establishing an accountability plan. So one of the measures that was included in this initiative was VTE1, which is the administration of prophylaxis to prevent venous thromboembolisms. And the guideline is that patients should receive VTE prophylaxis either the day of or the day after a hospital admission. And the research does support that best practice prophylaxis does reduce VTE incidence by an estimated 70%. So the idea is that really every patient who's going to be in the hospital for beyond a day should be receiving some sort of either mechanical or pharmacological prophylaxis to prevent VTE. So we were working towards our 96% goal for VTE1, and we identified that we really had gaps in 2 areas. One was in physicians ordering the prophylaxis for the patient. The second area was that the prophylaxis needed to be administered, which was primarily a function of the nurses. So we actually implemented a number of strategies to help improve ordering performance. So this was more focusing on the physicians. We created VTE order sets. We started to do a lot more around measurement and feeding that information back to individual clinicians so they could understand where their performance was. And we actually did some pilots around pay for performance. So we actually internally incentivized providers to improve their performance to the 96%, and if they did that, they would get some sort of small amount of money. And so those and different strategies actually, we saw great improvements in the ordering of the prophylaxis. I think we went from somewhere in the 60% range to close to 94 or 95% across Johns Hopkins Hospital. But then we had to think about the administration. So we were finding that we were still ordering the prophylaxis as we should, but that administration was not necessarily happening. And what we were often finding was that patients were actually refusing the prophylaxis because they didn't quite understand what the function was. And what we were finding was that the non-administration of the prophylaxis was 14.8% in the Department of Medicine and 6.2% in the Department of Surgery. So the way one strategy we used to conquer this issue was we created an electronic real-time escalating alert with a patient-centered education bundle. So if the nurse documented that a dose of prescribed pharmacologic VTE prophylaxis wasn't administered, that actually generated an alert to a nurse educator. And that nurse educator would actually come onto the unit and talk to the patient about why that dose wasn't given, what their concerns might be, explain the risks and benefits. And what we found was after implementing this alert and an education bundle, that the prophylaxis non-administration decreased by about 30% in medical patients and about 60% in surgical patients. So what I think is interesting is it ties measurement. So we were being measured on this VTE1 measure that was tied to what we were trying to achieve as a health system, tied to pay for performance programs, but it also tied well into clinical guidelines. Like this was the right thing to be doing for patients. And so how do we use the electronic health record and measurement to actually, in a real-time situation, improve our performance both on the measure and hopefully improve care for the patient? So that is a quick overview.
Okay, thanks very much, Matt. Another perspective on safety and how electronic data can be used to improve safety. We had a couple of folks addressing safety. Maybe, Paul, you'd like to share some comments?
Yeah, no, I mean, that type of example is very heartening to me because that's what it feels like we need to be doing sort of more of writ large, right? But I mean, I'm sure that was not a small effort, right, to make that, one significant change in one health system. So I mean, it does feel to me like the challenge that sort of faces kind of all of us collectively is how do you systematize that type of performance and be able to do it in real time and in a way that meaningfully moves the needle.
Right.
Right. And I think you're right, scale. How do we scale this? Yeah. So this was one particular issue in one particular hospital. And to your point, it took a lot of human financial resources to make happen. Yep. And how do we scale that to, what we've talked about? How do we create feedback loops? I mean, that's what this was, the feedback loop to say, this patient hasn't gotten the prophylaxis, what are we going to do in real time to address that? So that A, the patient has good care, and B, we hit our measure as well.
How did you surface the alert to the educator?
My understanding, so let me maybe clarify. So the work I'm presenting today is the work of a VTE collaborative led by Dr. Elliot Hout and Dr. Michael Strife. My understanding is I believe the nurse educator got some sort of text or page to alert him or her that this hadn't been done, and perhaps also gave like the unit information of where they needed to go.
I thought it was interesting that they're documenting non-administration, which is like documenting safety, and that's to proactively document, I see a safety issue here. Was there, maybe you don't know this, but was there no way to be able to have some, kind of solution or some kind of algorithm to be able to look at the conditions and then be able to say this patient should have been getting prophylaxis and then be able to trigger some kind of alert based on that, rather than someone having to document something and then triggering an alert, which is kind of like picking up the phone and calling the educator.
Right. Yeah. I think so you definitely could, I think, set up some sort of logic around, rule-based logic that, if the administration time had passed 3 hours, it would automatically generate, the alert to the nurse educator. I don't know the reason why they chose to go the approach that they did, but I would think there might be opportunities to do it in a slightly more automated way.
Okay, thank you, Matt. And now we're going to move into our public comment session. We have received a slew of chats from the several hundred public participants, and we really appreciate that. In addition to my posing of a few of the questions to our panelists right now, we're going to be collecting all of these chats to have them be input into our report to ONC. So keep those coming, even as we continue the discussion here. The first sort of theme across the chats that I want to pose to the panelists and get your reaction to is, what is the patient's role in these innovative approaches? How can patients have input directly or maybe indirectly in reaction to what's being generated electronically? And for those who aren't interested, that's for those who are, for those who aren't interested or maybe even are non-compliant, I mean, how are these innovative approaches bringing the patient into the care process? Who wants to start on patient's role here? Frank?
Well, yeah, this is Frank. First of all, it's a great question. We are anticipating the patient's role, but right now we are so far behind on the clinician's role, we're focused there. We think that when we start talking about episode-based care and a continuum of care, there are all sorts of patient moments in between visits where things are happening, and today those things typically get a phone call to the doctor's office. My wound looks like this, or my diet is this, or something's happening in my GI tract, I don't know. And today we're getting all sorts of selfies and pictures and all of these other aspects. How do we actually incorporate all of that into the record? How do we make that part of their care plan and create those elements of applications or services that could actually be part of this? I've seen a couple applications that take on a chronic disease and ask patients who are having particular issues with a chronic disease, how are they doing? And we're approaching a season right now here where asthmatics are being exposed to the spring and what happens in the springtime. How do we have activation of the primary care relationship to the asthmatic to get in front of that disease and create that communication there? And then how does that patient communicate back, or a change in medication, or a new problem with the change in medication? There are all sorts of communications. We've relied on traditional office visits and trips to the emergency room, which may not be necessary given the infrastructure that's sitting out there in everyone's hands in a smartphone. We've not begun to leverage that we're worried about EHR to EHR communication. What we should be thinking about is, what does the entire digital health information afford us to do for a patient in the continuum of care?
Yeah, and on the safety side of the world, so we have a patient feedback component as well that's actually part of that system, which, I mean, again, candidly, when I first came to sort of the safety space, not being sort of an expert in that area, being more of an interoperability and exchange person, it was sort of a question to me, like, well, why exactly are we capturing, that too? But what became very clear very quickly is a fair amount of patient safety or patient feedback that we received, while some of it is not explicitly safety related, an awful lot is, right? So even though it's sort of a complaint, like my discharge instructions were sort of unclear, now I don't know what medications to take. Well, that's sort of a feedback, like do a better job about making some clarity on this, but that has a real impact, right, to patient safety and to things like readmission, these kinds of concerns. So the patients have a very active role in this, and strong sense in my world of agency in that. And I think, we are looking ever more for the tools to put in the patient's hand to sort of disintermediate or remove the need for disintermediation, so they can just directly provide that type of feedback in. But then again, you're back to that same someone that has to look at it and sort of make determinations. So to the extent that the system can help to sort of shunt those things into the appropriate category and to start the investigation process to some degree to make those determinations, even if you don't get it absolutely right, just because of the volume that's involved, you can't sort of let the perfect be the enemy of the good.
Seems like there's some, now there's some extensions of things that are already within kind of the paradigm of interoperability. So you've got, more devices in the home that are tethered in some way, scales, whatever, right? So that's sort of an easy one, and we'll probably continue. But I wonder if, in a way, it's some of the same problems that we're talking about on the provider side, which is how do you get data that's good data and that really captures something and that isn't about a patient documenting for the sake of documenting, right? In Massachusetts, I go to a provider and then I get from Press Ganey or whoever a 30-page, CAP survey or something, which even in this business, and I throw it away. It's like I'm not gonna, I'm not gonna do that. So the question is, how do we do this in a big data way? Where, in healthcare, a lot of people would say, oh, big data, but it's like big data isn't volume. Big data is about different media and different types of data, right? So how do I tap into Facebook streams in an appropriate way? Facebook or patients like me or, all of that other stuff to be able to sort of tap into that, which is first off, which are just things that patients are just going to do because they're just people and not, documenting separately, but, you're able to sort of tap into the stream of their lives in a way that's appropriate to be able to get that. But I think the second problem that gets posed or that we confront there is how do I do the filtering of appropriate signal to noise? Because most providers I know do not want, sort of Fitbit and this and that plugged into, their EHRs. They might be willing to entertain it, but they don't, they don't really know, just give it to me when, in a way where I know that there's something actionable that I need to do. And so that question of intermediaries, of, who would actually do that. And in my mind, it could be maybe the CVSs or the Walgreens of the world become, sort of that natural locus because they already have such, such information, so much information on patients in other parts of their lives. And they may be trusted enough that a patient might be willing to say, sure, I'll, send my Fitbit data to you. You already have my prescription information. I already have my CVS card, and you give me these, CVS bucks every time I go. So I've got some kind of affiliation with you, and then they play a role of saying, we'll take all that. We'll do a signal to noise kind of thing, and then we'll, sort of figure out how to send that kind of stuff to your provider or something like that. I'm not just thinking out loud here, but there's an important role for an intermediary to play that big data role, I think.
Good idea.
Yeah, this is David.
Go ahead.
Can you guys hear me? Oh, good.
Yeah,
I was gonna chime in on that. I think that you uttered the most important word in getting progress here, and that is trust, and having a trusted intermediary of some kind that does this work. So many of these conversations for me come back to architecture and how and where the data lives and moves and where consent lives and moves. And we really committed ourselves to building something we call patient-centered data homes, which, like the patient-centered medical home is supposed to coordinate and aggregate all of the decisions about my care. Patient-centered data home should be my longitudinal health record that follows me where I go. And having such a thing allows us to do the patient-centric measures we were talking about earlier. It allows then the patient to have centralized consent, for example, which is a really important thing we have to get to, I think, instead of consent scattered across everywhere they got care. And it also positions us to, quite honestly, just start to move towards a learning health system, because you can start to have patients opting into studies and other things, but not feel like, what's the statement that always used to be uttered, nothing about me without me, right? I think without having something like a patient-centered data home that the patient plays an active role in, we aren't going to get there from here.
Great, thank you.
I think the last thing I'll just mention quickly is that we need to separate out, in a way, how we capture data that is about sort of the hotel services that a provider provides, right, which is like the Yelpification of this stuff versus what's really important from an outcomes, a true, sort of outcomes perspective. Because a lot of that data right now is, I'm really happy with the valet service you provided, so I gave you 5 stars.
Right. Let's take the next question, which is from one of the public commenters who said, many of the innovations that have been described today come out of large systems or other kinds of organizations with sophisticated IT capabilities. What about small community practices, rural health providers, those who serve the disadvantaged, like federally qualified health centers? How can we bring them into innovation?
I think we first have to get them off the fax machine. I think if the majority of their communication is by the fax machine, this is going to be a very tough activity. And so somebody mentioned direct trust earlier. It is not a perfect solution, but it's a starting point. And so I think we have to really look at the communication that's happening, because large percentages of communication, particularly to payers and to government services, still happen by the fax machine to those more rural and fairly qualified health center type settings. And so the migration to electronic, digital type approaches has been a little slower. Even some of the funding didn't come to some of those places appropriately. And so I think our expectations of what can be achieved have to be adjusted a little bit. And then I think somebody has to underwrite or subsidize some of that activity because it's valuable to someone else that they be electronic, more electronic, than asking them to sort of put forward the resources that it's going to really take because they have other activities that are consuming all of their limited resources. Because those groups in particular often don't have resources. Right. And so it's a resourcing issue as much as it is a willingness or ability.
So I'm taking off my college's surgeon's hat and putting on my former life hat, where I was very much involved in this environment. And what do you do? I don't totally agree with what was just said, with what Tim was saying, because it's actually making a capital investment's hard because they're tight budgets. But if you make the right capital investment, you can actually spread a lot of good and actually end up saving money. So yes, it cost a couple $1 million a year to put a system in that ended up saving $10 or $15 or $20 million a year just by managing pharma. And I couldn't manage it in a paper world. I needed a digital world to do it. So there are good business cases for doing this. But I think the problem is bigger than that. There are some great foundational opportunities to build an infrastructure that will create more affordable spread so that you can get adoption from systems that don't have the ability to put the foundation in, and they can get the spread they need. I don't think the spread is going to come in their EHRs. I think that's probably the most expensive way to do it. I think there are alternative ways of creating widespread and using cloud and using APIs and helping them in that way. But that needs to be a well thought out, coordinated strategy that identifies what are their most pressing needs and building upon those most pressing needs and using the modern vehicles that are out there to create the spread. Right now, they're all trying to do it as a bunch of onesie, twosies, one-offs, and they're wasting resources. They're out there trying to be a Johns Hopkins or an MGH. That's not going to happen. They don't have that kind of capital to do what's happening in those other places. So how could that be created in such a way that we could layer on the infrastructure and create the spread they need and give them the opportunity to look at a panoply of options that would fit each one of their environments, because each one's different. There's a rural one and there's an inner city one, and they're completely different,
but neither have the resources to lay down a foundation and then build upon that. We're going to have to help them.
But the overall theme is that they must transform in some way to adopt technology, right? They can't kind of be an outlier to that effect. Even some of the large professional organizations that we work with, have memberships that include many of those practices, but they are realizing they can't address everyone. At some point, people will get left behind. But ideally, that's not the case, but they must. Yeah.
We got a open-ended question I think you all will be interested in responding to. What about a universal patient identifier?
Mm-hmm. Hey, this is David. I'll take that.
We talked about that during the break, too.
Oh, you did? Oh.
Well,
I mean,
we doubt you'll be.
Sure. So tying a little bit to the previous question as well. I mean, we're a health information exchange among other things, so we consider ourselves to be part of our mission to cover that white space for rural small providers. And our major issue right now is not whether or not they have an EHR, it's just when they're going to change EHR vendors, which they do, like socks at this point. Then when it comes to the identity management piece and the universal identifier, I think, we might set up a universal identifier. It would just be a matter of time before it would be as useless as a Social Security number in some populations. So we have, among the health information exchanges, come up with a different approach we would like to take. We have a group called the Strategic Health Information Exchange Collaborative, which is now 50 HIEs around the country, and we cover about 200 million Americans. And so that means we're resolving a lot of identity in our specific geographic regions. And when we execute this model we call the patient-centered data home, I'm sending, say a patient from Arkansas comes to an Oklahoma hospital, we route the ADT message back to the Arkansas network along with our resolved identity for that patient, so that in Arkansas they now know definitively how Oklahoma interprets that person, and they can send back to us their resolved identity. So we do think that cross-region identity resolution is critical, but it need not get any bigger than it needs to be. In this case, Oklahoma to Arkansas, just where the patient is gone. And so we aren't feeling the need really for a nationwide patient identifier at this point.
I would just like that. I actually agree with David on that, which is a little bit contrary to some other views here. But and it feels like in some ways it would be great. It might sort of get stale over time as people start to do perverse things with it. But it also feels like if it doesn't come, at least with our data warehouse, we get tons of records from tons of different places. That doesn't feel like the most pressing issue we have. There's 5 other things on the list that we've already talked about that are much harder for us to figure out. The patient matching thing, we're able to figure it out to our satisfaction, and we haven't really seen it. It's a question of efficiency. We'd be able to do it cheaper, but it's not like we're not able to do it. I'd just like to go back to the previous question for a second, which was about the rural and how how can others who might perceive themselves to be in situations where they can't move forward. I guess I would have 2 comments. I would just go back to what we've been talking about, which is just getting the basics is really important. And I don't think it's as heavy a lift as a lot of people might think. Right? A lot of that is more just about alignment and convening and process and agreements. Are we going to create this web of interoperability of simple stuff based on direct? Right? I'm going to push a discharge summary out to the PCP every time. I mean, it's shocking how many hospitals don't do that. Right? The majority, I would say, don't do that for every visit or for 80% of the visits. Right? And I'm going to push a referral to the hospital or to the specialist for every transition of care. Right? That's all relatively simple stuff now that you can do out of your EHR. It's a human issue more than anything else. The second thing I would point out, just to make you feel comfortable, is that the advanced systems aren't as good as you think they are. We work with a lot of them, and they're really cool with rocket science-y kind of stuff that gets, and sorry, with all due respect, that gets publication. But when you look under the covers, they're not doing a ton of the basic stuff. We work with a lot of advanced systems who aren't just sending discharge summaries to the PCPs every single day. They're not doing that, but they're doing incredible work on genomics, machine learning, all of that. But those are 2 different levels that they're playing at. Yeah.
So the identifier, whether it's a national identifier or not, what we really think of that process is data cleanup process, and that's the fundamental issue, is data integrity and data cleanup and provenance. It's not the magic of an identifier. It's a systematic way to do the cleanup that's across organizations. And so you can do that within a jurisdiction just fine, and then figure out a federating type model once you get a certain level of scale. But you still need to have a data cleanup process that spans boundaries.
So, Rob, thank you very much for sponsoring the event today. If I had 10 more minutes, I would ask another question of all of our panelists, which we received from a number of the public commenters about, so what do we need, all of us who are working on these issues together, from federal government in terms of support, from ONC, from CMS, from others who might be able to help address some of these issues. Perhaps in your closing, you can give us some insight into how you're going to be incorporating this into your work, and what else you might need from the folks in this room or attending as public participants today.
I think that's a great question. I think we need a lot more than 4 hours to talk through all of the different permutations of it. I think we heard some of that in the discussion today, and that was the point of pulling this together so that we could begin to hear some of those things. I think this is a first step as a listening session. We will probably have a number more of these to talk about some different topics on things. I will tell you that as we have been building up to this event, I personally have had a little bit of anxiety about it, just from a how you pull things together, logistics of it. Anybody who's done an event like this knows that it can go a lot of different ways. And I think we've all probably been part of or put together some that have gone off the rails and just not hit what you had hoped it would hit. And I just want to say thank you to everybody who participated in this, because that was not this event. This has been a really deeply informative event. I appreciate not only all of the presentations, but I think it was very wise for us to put together some time for all of you to talk to one another as well, because there were some very revealing things that I felt like came out of the discussions that you all had with each other. The genesis of this started with this very seemingly simple, infinitely complex question of should we, is there a better way to think about putting together quality measures, right? I think something that Stan had on one of his slides, which I may inscribe over my desk in stone possibly, was the idea of improving the game, not improving scorekeeping. And I really think that as we began talking more about this, is there a better way to put together quality measures, that's part of what came out of it, is that, at the end of the day, we're not talking about a better way of scorekeeping. We are talking about how do we move the needle on things in a way that really gets to better patient care. And very often, somebody said that here in the presentations today, quality measurement is a separate entity from quality improvement altogether. I think we heard a number of things that talked about how to improve data so that the measurement is useful. It's not, I think, about better scorekeeping. It's about scorekeeping that is useful for actually playing this game. Frank, at one point in time sort of said, I don't often ask for big government, but in this case, it would be great to have big government. I think for us, the purpose of being able to listen to all of you is to not think about necessarily big government and where we intervene, but, smart government and what are the places that we need to push, and we can help align. And we can help think about process and governance and all of those areas that really can make a difference. To get to what we've been hearing as well, let's look at something that's useful for us for quality improvement. How do we get into that cycle where it actually feeds back and is part of a learning healthcare system? Couple of basic housekeeping things. We've gotten questions over and over again. Yes, if you missed any part of this, if your colleagues missed any part of this, there is going to be a web recording that will be available. We will send that link out to everybody through the same mechanisms we sent an invite to register, so be on the lookout for that. We hope to have something up soon. I absolutely want to be able to hear from folks publicly. So if you have comments that you specifically want to reiterate, if there's anything you want to follow up with us about, if you want to make sure that we have something on our radar, please feel free to send public comments to me at robert.anthony@hhs.gov. We're not going to be able to respond to individual questions, but I would absolutely love to hear if there are things that you wanted to contribute to this. Thank you again to everybody who presented. Thank you to Discern for running an excellent event, and Tom for being a great moderator on all of this. So.
Thank you, Rob. The web meeting is now adjourned.
Thanks, Tom.